Always very official. Love it. All right, this meeting's come to order. Welcome, everybody. Before we get rolling, I'd like to introduce the interim director for the Healthcare Authority, Marianne Lindenblatt. I think paths probably have crossed in the past with her. She was longstanding Medicaid director here at the agency, and she's come back to take care of us while the Ferguson administration does a nationwide search for a new director. And Marianne, would you like to say a few little?
Well, first of all, it's really wonderful to be back, and I'm enjoying it, and but very much time limited. I enjoy retirement too. So always something but it was an honor for me to be able to come back to the Healthcare Authority and sort of shepherd folks through this next 2.5, 3 months, maybe a little bit more.
Maybe 3.5, 5 months. Like that.
However it works out. But I just wanted to come down and say hello and just introduce myself. And Dave, and you'll always know how to get a hold of me if you need to talk to me about anything. And again, it's just a delight to be here. And I wish you a successful meeting or retreat. We've got a day together, and I'll try to come down later and see how things are going. But again, can I just meet the board members that are here, and so that would be great, and maybe tell me where you're from to start with.
Hi, I'm Laura Christopherson. I am Central Kitsap School District, but I'm here representing Washington Association of Colleges.
Carrie Schaefer. I am sort of a free-floating something or other.
Well, we need those.
I retired from King County. I spent many years doing benefits design, strategy, those kinds of things.
Oh, great background.
Good morning. My name is Pam Cruz. I'm a middle school special education teacher in Franklin Pierce, and I'm representing the Washington Education Association.
Thank you.
Hi, good morning as well. I'm Myra Johnson, and I'm retired now.
Okay. Congratulations. It's a wonderful feeling, isn't it? It will get there.
Yeah, school counselor for 31 years in the Clover Park School District.
Nice to meet you.
Katie.
I know Katie.
So Katie Hacknell, not on the board, I'm here as board counsel. And I spend most of my days representing the both PEB and SEB programs.
Thank you.
Virtually, Donna.
Hi, Donna Hanson-Murray, also newly retired.
Congratulations.
Representing classified, thank you, representing classified staff, formerly a technician in the school district.
Omid.
Good morning. My name is Omid Hidari. I'm an assistant professor at the University of Washington School of Nursing.
Welcome.
Thank you.
Nurse. That's what I'm a nurse by background, so it's wonderful.
Oh, wonderful.
Yeah, you had her at nurse.
Yeah.
You said nurse, she's like my people.
Yeah.
Terry.
Hi, good morning. It's Terry House. I represent the Arlington School District up in Arlington, Washington, classified employees.
Nice to meet you.
And last
Good
but
to
not
meet you.
least, Allison. No, that makes sense.
Allison Folson.
Oh,
You know.
Well, please greet her for me. Come back down. I should say hello to her. Well, I'm going to go back to a whole list of meetings today, but I will probably stop back by later today. And it's just wonderful to meet all of you and here. So thank you for your work. Thank you for your willingness to serve on the board. Very much appreciated.
So when Marianne came, we talked a little bit about divide and conquer. The director of the agency is technically in charge of both boards, PEB and SEB. But Sue assigned PEB to me, and so Marianne has said, okay, you keep doing SEB, she's going to handle PEB, but you may see us interchangeable. So there may be, I might have an issue or something, I'm out, and Marianne will be here and vice versa. But we wanted to get you an opportunity to meet her, and
I'll be around a while. Thanks.
4 or 5 months.
Thank
Thank you, Marianne.
See you all later.
Yep. All right. Well, we've got the intros to the board done, but I'm going to go through the preamble a little bit. Welcome to the 2025 SEB Board Retreat. Our meeting this year is going to be, or all the meetings this year are going to continue to be hybrid. Healthcare authority staff will be on site as much as possible. Board members and other attendings have the option of being on site or attending virtually. For our Zoom attendees, our opening slide has information about how attendees can turn on their closed captioning. Laura, you already had a chance to introduce yourself, so we're going to go ahead and skip over that part. And again, my name is Lou McDermott, and I'm the Deputy Director here at the Healthcare Authority and the Board Chair. With board members attending both in person and virtually, it's going to be helpful to the board to hold their questions until the presentations are done or when the presenter pauses and asks for questions. Board members attending virtually, we're going to be watching for your Zoom hand. There's no resolution scheduled for today. It's more of an informative meeting. As a reminder, the public has questions during staff presentation. The presenter's contact information will be included at the end of the presentation so the public can send emails and ask questions, things like that. And there will be an opportunity, I believe, at the end of the meeting for public comment. All right, Dave's going to give us an overview unless somebody has any questions on today's agenda.
Good morning, Chair McDermott, members of the board. I do want to acknowledge Laura's first board meeting. I think she got to say that as she was introduced herself to Marianne. I do want to, if there's any other introductory pieces you want to make, would I introduce yourself? It was very quick with Marianne, but you're welcome to do a little more introduction. Laura's been on one of the stakeholder work groups. We have many stakeholder groups that we have a cadence of meetings with roughly every other month. We have one with pet benefits administrators, one with SEB benefits administrators, one with pet labor, one with sub labor, one with retirees. And Laura is part of the SEB benefit administrator group that we've been consulting with for the past couple of years. So she definitely is very aware of a variety of aspects of the program. So just wanted to acknowledge her prior service in one capacity and now board service. So today is our retreat. It's a slightly more informal process. We always have an educational aspect that we start off the season with. We thought, given the plethora of provider termination notices that happen as a more unfortunate standard practice that our members are experiencing, that having a conversation with the carriers here with you about provider networking and all the intricacies of managing networks would be an excellent research educational part of the meeting. Then we will have a guest star, our interim budget director from the Office of Financial Management, to talk about the state of the budget forecast and revenue and expenditure and challenges that many of you have heard about in the news or in your work, but just put a little finer point on it from OFM's perspective to kind of paint the picture of what we're all going to be working in, the environment we're going to be working in for the next couple of years. Then we will begin what I always say is the past, present, and future part of the meeting. We will go into the past to open enrollment and talk about the results of open enrollment. Then we'll be in the present, talking about some of our ongoing benefits 24/7 challenges, trying to raise some awareness about those pieces. The legislative update, we're about a week and a half into session, and we have Governor Inslee's proposed budget that we'll share insights for you, but an emphasis on that it is Governor Inslee's budget, not Governor Ferguson's proposed budget. Then we will talk a little bit about the results of collective bargaining, because there's a new benefit that is in the collective bargaining agreement that would go into effect in 2026. And so we'll have a presentation about that. We always have at the retreat the annual what are types of the benefits improvement cycle process that John talks about, and the brainstorming exercise there, which obviously in the environment we're going to for state budget purposes is a little bit different exercise perhaps, but John's going to talk through that. We did an employee engagement result survey that will have the results gone over by Missy and our team. And then we always like to do a couple of Medicare presentations from the SEB board to help people realize what is going on in the PEB side of the house as your employees or some of you board members graduate, as I say, into retirement and the experience that is happening and changes that are happening in the Medicare space for the sister program. I'll do a preview of coming attractions for the year, and then done for the day. It is a jam-packed day. We always have one day that's almost completely full, and then we try to have half-day meetings the rest of the year. 2 more reminders: if we have an emergency, we will walk purposefully across into the visitor parking lot.
And just for Laura's benefit, we all laugh at certain things because we've developed it over the years. And
I used to say run frantically.
You used to say run. We go, you're not going to run. And so he is. So if we all laugh and you want to know, like, why is that funny? We will tell you.
We're walking purposely. And we also have restrooms. When you go down the hall here, look, if you see elevators, look to your left, and there are bathrooms up to your left.
And there's
you
nothing
go
funny about that.
Whenever you need to go, we will have some breaks. We will have some breaks. I'm notorious for forgetting to put breaks into the agenda because I just kind of just keep going. But others remind me of that. We try to make sure that those actually happen. But if you do need to get up and go, please do.
Exactly.
Allison,
would you like to introduce yourself?
Good morning, everyone. Allison Polson from beautiful Valley Forge, Washington, where it is 15 degrees out, but blue sky everywhere.
Well, there you go. That's something. Allison, you've worked with Mary Ann Lindblad, correct?
I have spent a lot of time with Marianne over the
Well,
years,
she is
especially when she comes to visit her hometown of Spokane.
There we go. Well, she is our interim director, and she came in this morning to say hi to everybody. She'll probably be here for lunch with us as well.
Oh, fantastic. Thank you.
All right. We ready to go? All right. First presentation, provider networks discussion, is going to be a educational panel discussion regarding provider networks facilitated by John Parton. He's our benefit strategy and design section manager in the employee and retiree benefit division, which from now on we'll refer to as ERB, but that was for your benefit. And there are no materials. This is just a verbal exchange. All right. John, you with us, bud?
Yes, I am here. Thank you, Chair McDermott. First, want to apologize for not being able to be there in person, but that's for your benefit, not mine. I'm being told that I'm pretty highly contagious right now, so I thought I would not share that joy with any of you. As Dave mentioned, we like to have an educational sort of panel discussion to start these retreats, and today will be no different. We've asked some of the provider contracting executives from some of our payer partners to join us and talk through a variety of aspects of what's changed, how they view the provider structure and the timing of the provider contracting, and what some of the future might hold. And particularly, as Dave mentioned, given the perception that there has been a significant increase in the number of mass provider termination notifications, what we're doing about that and what can we do about that to kind of insulate members from the being stuck in the middle of it. Because as we all know, one of the first messages we typically hear is it will get resolved. This is just part of the negotiation strategy. And with them happening more frequently, that's hard, right? From a member perspective, because you don't know, will it actually get resolved? So that's a piece we want to kind of talk through today and get our subject matter experts, the execs here, a chance to give us some insights. So I want to thank each of the executives from our payer partners for their availability today and participating in the discussion. And I thought we'd just start by having each of you give a quick introduction of yourself to the board, and then we'll kind of run through a series of questions and just hopefully have a more organic discussion about all of the topics that I just shared. So I'll pause and please introduce yourselves.
Hey, John, just real quick, if you're having to go have a coughing fit or, do something, just go ahead and put your hand up, and you don't have to type in anything in the chat. Just put your hand up and we'll know that you're just taking a moment. I appreciate you doing this today. I know you're not feeling well, man.
Nope, no problem. I'm just really, for this type of discussion, I would much rather be there in person and with the board in person. So I truly apologize for not being able to do that, but thank you. Okay, so why don't we start with, do we have Denise from Regents?
You do. Hi, Denise Corcoran, Regents Blue Shield, Vice President for Contracting for the state of Washington. And I've been with the plan for a little over 2 years now. I have about 2 decades in provider contracting and provider network management. I started my career on the other coast at Empire Blue Cross Blue Shield in New York. And then I ran the contracting team in a small physician-led community health plan before making the journey out west. So thanks for having me today.
Thank you, Denise. And I think I see Jen Sanders from Primera.
Yep. Good morning, Jen Sanders. So I work with Primera. I'm the Vice President of the Provider Solutions and Strategies, which is contracting, provider contract generation, compliance, all those good things, provider relations. I've been at Premier for 30 years, born and raised Washington State. So that's my bio because I've had one career. So anyway, nice to be here and thanks for having me.
Hello, Alicia Broussard. I am the Vice President of Contracting, Network Operations and Strategy for Kaiser Foundation Health Plan of Washington. We have the same job. We all have the same job. I've been with Kaiser Washington since 2021. Prior to that, I have a couple of decades as well in healthcare, starting my career in Northern California, actually. Prior to coming to Washington, I led our contracting operations for our Northern California market for Kaiser Permanente. Prior to that, I was with Children's Hospital out in Oakland and a couple of other hospitals and another one in my early career with Prudential.
Okay, so then thank you. So again, thanks for participating today, being on site. And I think to kick things off, I just kind of want to set the landscape. There provider negotiations, and I speak from experience on this, are multifaceted, right? I think we all appreciate that. And it's a very complex set of factors that typically impact those negotiations. It's not as simple as we just go in and negotiate rates with a provider that they'll accept for reimbursement for their services, but there are also things about administrative burden. There are things about consumer expectations with provider networks. So there are a variety of factors that are in play when a contract is negotiated. And while there have always been some number of contentious negotiations, in the past, it seemed that it was pretty rare for those to become public. And it seems that, as I mentioned before, and Dave mentioned, the frequency with which there are mass termination notifications going out has increased over the past several years. So we'd like to get your insights and perspectives on the provider contracting landscape, the structure and timing, as I mentioned, changes in the dynamics post-COVID, ways we might be able to insulate members from termination notices, particularly given that it seems that there are so many provider contracts that renew on a 1/1 effective date, right? And from a provider or a member perspective, they've just come through open enrollment many times. They've made a selection based on what they understand the network to be. And then they're caught in the middle of this mass termination notice for a 1/1 effective date or shortly thereafter. And they're not sure what to do, right? I made a decision based on what I thought a network was, and now it might not be or appear to be the same. So particularly those where that seems to be part of a normal negotiating strategy, like I mentioned before. So any new developments in the provider contracting area, alternative payment methodologies, value-based reimbursements that might impact the frequency of those termination notices, those are all things we're going to try and touch on as we go through this conversation. So I'll start with kind of the high-level starting point of that conversation. Generally speaking, how are your provider network contracts staged? What's the timing of the contracts? And how is the negotiating process managed, both for your staff, understanding that you have a certain set of needs and the providers also have a certain set of needs? So can you share some insights as to what that timing and structure looks like? Anyone can start.
So things have changed. So historically, our contract negotiations have been pretty transactional. 6 months ahead, provider sends a proposal, we counter back, we volley back and forth for about 6 months. We get the contract done and everything's peachy at a good rate. The contracts now are coming in with, as John mentioned, termination notices on top of what the double-digit increases that they are looking for. So preemptively of that, what we've started doing is instead of waiting for the 6 months to come up, we're creating a comprehensive proposal about a year and a half ahead. of time. And I can't do all the modeling and the numbers because you need all that later on in the negotiation, but putting our priorities down and talking with the providers and the hospital systems earlier to find out what their priorities are to see where we can line up. Now, it hasn't stopped the terminations from coming in, but it's given us more time to try and get those contracts negotiated to both parties' needs without having to send out those member letters. The OIC has a requirement that we have to send member notification 30 days prior to the ending termination date. Otherwise, we wouldn't, because it just causes a scare in the community. But I'll give you an example. Like, we had a big contract we just did, and it was a 1/1/25, and we gave them a proposal in November of 23. Pretty comprehensive. Tried to get them engaged for a very long time. They did come to the table in earlier than June, so we had more than 6 months. But the current contract we have now for 4/1, two have to play in that space, and the provider did not want a proposal from us and did not give us a proposal until 3 weeks ago. So now we have this much time. Now, there isn't a termination on that proposal, thank goodness, because we'd be scrambling a little more than we are. But used to be short and sweet and to the point and fair rates, and now we're battling for everything. Providers too, it's a two-way street, and it's taking much more time. So we're adapting to that in the way of how we communicate.
I have a question. Do you feel like you're trying to get way ahead of the game, send them stuff super early? They're like, that doesn't benefit us to negotiate early, so we'll just kind of wait till we get near the end. Because I would imagine that pressure from letters going out and people getting upset because their plan, their ability to work with a certain provider might go away, benefits the providers at the negotiating table. So is that just a strategy, or is it there's something else going on that they can't sort of get to it on time?
I think it could be both. It could be it's strategy to send a termination with a contract proposal for sure. This provider that we've been trying to get a contract or a proposal for from June, they were in a fight with 3 other payers that had an earlier effective date than us. So they didn't have resources enough to manage our negotiation because they had 3 major hot terminations on the table before us. So it just depends. And some providers are really willing to come to the table and talk, and others are like, you're on my schedule and we'll send it to you when we have it.
So without divulging company secrets, what's the strategy to counter that strategy? If we're waiting till the last second to negotiate to put heat on the carriers, how do the carriers respond to
that? We're prepared. So we have done all of our modeling. We've already gotten with our general managers, so when we negotiate, it's not in a silo in our network team. We get with our general managers for our individual line, our community rated line, our group. We've got self-funded, we've got fully insured, shared admin, federal employees. We get with all of our people that we deal with internally to talk about what our priorities are. So we're ready to go when it comes in. So we're not flat-footed. That's the only thing we really can't do, to be honest. And maybe you guys have something cooler you can share it with me to help me out, but that's where we're sitting right now.
No, I would agree with a lot of what you said so far, Jen. I also want to comment though and add that about 98% of the network, give or take, maybe 95, are what we auto renew, right? So they're your community docs, your independent providers, specialty providers, some of your ancillary providers like durable medical equipment, home infusion, those types of providers that round out the network. They all typically just float year to year without much disruption. On these large scale terminations come from your providers that have leverage and make up probably, like when you're talking all about your whole network, they're not the bulk, but yet they have the leverage and they carry the weight. So it does feel recently now that there is a lot more in the public sphere going on, and I don't know about my counterparts here, but like negotiators prefer to do our work behind the scenes. Like we like to keep things humming. We're good at what we do, and we have great relationships within the community and with our providers, and we prefer to have those behind the scenes. We don't want to, it's not our intent. But it has happened lately that we are seeing more and more of our providers that are larger and had some real economic downturns coming out of the pandemic, leverage the fact that they have this market share. They can issue a termination notice. They can wait us out to get the best deal, you know, possible in terms of reimbursement rates and administrative language.
Right, and to add to that as well, fundamental to this is both parties need to be able to play in the sandbox. We have to work together. And I agree with both comments. We are proactive. So the plan is to be proactive and to ensure that we are insulating our members ahead of time, to make sure that we are planning for any end dates in contracts. Some do have end dates. Again, the 5% versus the 95% may have an end date. And when they do, we're working ahead of time to ensure that we are negotiating that with the provider to get to common ground by the end date. The issue is two have to play. And in some cases, our providers do use the leverage, understanding that we would have to send notices out, knowing that that is the requirement, and using that to their advantage to obtain the rates that they are looking for. And our hands are tied in a lot of cases. That being said, we usually have a plan B, you know, as we're talking about, you know, bringing everyone to the table within our organization to understand there's a termination that's looming, and we may need to make alternate plans. There's always a plan B in every scenario. It's unfortunate that it ends up that way sometimes, but we have to plan, you know, hope for the best, plan for the worst. We do all of that planning within our teams and within our organizations. But it does take two to tango. Where we land usually is at something that works for both parties. But I think the notification really is what puts the patients a bit in the middle, and that's unfortunate. We don't want to see that occur. Again, a vast majority of our contracts are evergreen, so they auto renew. And so with that, we don't have this issue with every provider, but the larger providers that have the leverage too.
Would it be fair to say that the 98% that are auto renew are receiving less of an annual increase than the large systems who are negotiating heavily on a periodic basis?
Not necessarily. It depends on their payment methodology.
I was wondering, you know, when I heard that, I was like, oh, I wonder if these smaller providers are not receiving the same level of increases that the larger providers are, that's sort of pushing further consolidation in the market, because they're not getting the increases they feel they deserve. But if they join a larger system, then they become part of that. Is that?
I would say the reimbursement rates vary, right? Because you're talking about what the cost is to provide the service at the different types of institutions, right? So your health systems generally have higher costs. They have more overhead. They have acute care facilities that are open 24/7, whereas your commodity-based providers or your independent providers have less overhead. Doesn't mean they're necessarily reimbursed less. It's not apples to apples. It's a fair reimbursement rate that aligns with their cost structure.
But I guess I'm kind of interested in, it's like, I get the overhead piece, but you're still having year-over-year increases in basic costs between salaries and benefits. I mean, I think about our own PEB and SEB benefits each year just to maintain the same benefit. Dave, what kind of number was that? It was
Usually it's a couple $100 million.
to stay the same, just even. And then if we want to do more, it costs more. So, yeah, I was just curious about that.
Yeah, sure. And I don't mean to insinuate, I'm sorry if I did that, the rest of the network are not getting it.
Okay.
Yeah, and
I would add, I don't think the smaller providers provider shops are coming to us, and I can only speak for myself on this. They're not, as well, and it's high. They're not asking for the amount of increases that the systems are. So, and also not to downplay, but like 75% of our total allowed dollars flow through the big systems. I've got thousands of other contracts, but most of the money flows through these big consolidations. We used to have 15 big systems or 12, don't quote me, but now we're down to 7 or 8, right? Whatever it is. So completely have leverage coming for crazy increases. I had a rural hospital ask for a 75% increase. 75% increase. I mean, that is a lot, right? And with a termination on the table. Yeah. Yeah, with a term on the table. So
you can't lose them because you need them.
They are the only hospital.
That was the point I was just gonna throw in, that, John, I don't know if you were gonna adhere soon or not, but there's an important relationship here. Is when something spills out into the public forum, members understandably want the network to be as broad and include that provider. And that is the very leverage that is being potentially sought, and can result in possibly a higher agreement than would otherwise be reached for a particular rate. That then trickles over to member premiums. And just want to, there's often a disconnect in our members in understanding that the pressure that comes to keep the network as broad as possible can come at the cost of upward pressure on the very premiums that they pay. There's a direct relationship there.
Yeah, and the other point that I would throw in there is that it's not that smaller groups or systems or facilities or practices have less leverage necessarily than a large system, but the leverage is different, right? And so how they apply that in the negotiation is different. And that's part of what our payer partners are dealing with, right? And trying to manage on our behalfs. There are a couple of things that were said in the responses that I just want to pick up on really quickly. Are you all seeing any changes in the percent of groups that have evergreen contract renewals that are being renegotiated ahead of time, that they're approaching you to renegotiate versus what was being done 5 years ago? Or is it pretty much the same? And I'm curious about, for those that you're proactively going out to earlier, has that had any impact on that evergreen renewal process?
I would say that more evergreen providers are coming to us for increases in general. It's not a huge uptick. It's the big systems that are the problem. I think we'll all three of us can agree to that. That's where the major disruption and problems are. But that rural hospital, they wanted a 75% increase. They went to the media with this, so I can share it. It's not a secret. And they went to our constituents before. They went to groups and told them they were going to term before we got the term. So it was out in the public without our even knowing. People were calling us saying, hey, you're going to term it. You're going to be out of network. And we're like, what? We didn't even know we were in a negotiation. So no, but that's I think part of your answer, John. I think that answers your question, but the major systems are it. But I will say the major systems never go evergreen, but now they're trying to put hard term dates on the end of that contract renewal. So it will term if we don't get it done. Like Providence, we just completed that one 125. That's where we started negotiating in 23 for this contract. And if we didn't get the contract done by Thanksgiving, we were going to have to send member letters because the termination date is on the contract. It wasn't a termination. They didn't send a termination to us. It's just the fact that there was a hard term date. It was going to end if we didn't figure it out. So 2 different kind of things going on there.
And that's one of the other points I just want to make sure folks don't lose in the conversation. Payers have an OIC requirement around termination notifications. The providers don't have that same requirement. And so it's not that you couldn't send a notification much earlier if you wanted to as a payer, but the providers have no real constraint around when they send the notification and how they launch that, what they have to do in that process. So it's a little more structured and defined for the payers. That's part of what they're dealing with.
Yeah, you don't mind, John, I'd like to just comment on the notification. So we have a requirement to notify our members of a provider that they've been using may terminate. It's 30 days, it has to be in the member's hand 30 days prior to the termination. It also notifies them of potential eligibility to continue services for continuity of care. That continuity of care begins when the member receives that notice that their contract may end. And so at Regents, our practice is to follow the mandated timelines. We don't typically go any earlier because we don't want to shorten that time frame of continuity of care. We have had providers go out in advance of us, which causes a lot of, I would say, confusion in the market for the members in particular. We do then get a lot of calls, what is this about? And while we educate our frontline staff around what's going on, right, with provider negotiations, we won't, even with the provider going out in advance, we're really conscious of that timeline of continuity of care. We want members to get the best of that benefit in case of termination. So we won't change our time frame.
I'd also add that this is not limited to kind of your larger hospital health systems. We are seeing activity as well from some of the larger medical group, specialty group partners are also doing similar activities, whether that means changing how they're scheduling members or making an effort to communicate to patients that, you know, they're in contract negotiations. That happens quite often, and it's happening with the smaller groups too. And so there has been a significant amount of consolidation in the imaging space and other kind of ancillary spaces. And we're seeing that as well in that space. So we're also having to, I think, John, you said there are different strategies employed. This is another strategy that's employed with providers that puts members in the middle while we're in this negotiation dance, if you will. And so that piece is also a pressure, I think, that puts members in the middle as part of this process. And so we are learning to, again, be more proactive, which we have been pretty much all along. It's really about the resources on their end. Like we said earlier, if we have a provider that's already negotiating big, other payers, they're not going to use us as a first priority when we're trying to make that do a proactive negotiation with them. And we've been told that, hey, we're negotiating with agents right now, so we can't talk to you today. We'll get back to you in 3-4 months. So it does occur, and we're all in it, and we're doing okay. But it is, I think, problematic for our members who are sometimes in the middle because of the notices that we have to send out. I don't think we've had any significant terminations recently, but they do occur, and we prepare for that.
I'm going to go to Omid, who has his hand up for a question.
Hi, everyone. I have 2 questions. The first, I was curious, as a provider myself working for one of the bigger systems, so University of Washington Medicine, we're constantly told as providers, nurses, et cetera, that it's difficult to hire more providers, have more resources, because reimbursements from insurance companies are not where it needs to be to maintain. Like, we're always operating in a deficit. So I'm curious, it just seems to be an imbalance between providers coming to the table for more higher reimbursements to renegotiate versus what your formulas might say is a fair and balance. So curious what your thoughts might be around that for some of these systems. And then the second part of my question is, to be fair, and we've seen this a lot in provider spaces, is private equity purchasing a lot of private practice groups and coming in, I don't know a better way to say this, but to really try to get as much as they can, but while still limiting their services to members as well. So is that also playing a factor into the types of negotiations you're seeing in this space as well. So I guess it's like two different types of systems I'm thinking about here. One is the big academic or bigger medical centers, which serve wide populations, versus private equity, which is entering the space.
I can start with the private equity because it was actually a big, it felt bigger on the East Coast where I came from than it does here. But we are starting to see some, and it's not all private equity backed, but concierge type medicine practices where it's structured as not a covered service, and they're asking members to pay out of pocket like a monthly, like a gym membership fee, like a membership to the practice. Yeah, concierge, yeah. And so we've had some experience with that here. The way our member contracts are structured, it has to be a covered service in order to be a covered benefit. Most of what they're considering non-covered actually is covered. So it's led to some of those types of conversations. On the East Coast, though, we had a ton of venture capital, Oak Street, like a lot, gobbling up practices, almost kind of competing like with Optum for buying practices and then closing panels to payers. It was a very strategic move on to limit the amount of payers they were accepting, thereby limiting members' access. We dealt with that strategically at some of my old plans by, I would say, deepening our partnerships and our relationships with the primary care practices, helping them not to go in that direction, seeing where we could align on alternative payment models and more pay for value rather than the pay for widget or pay for service type of reimbursement that has largely made up our health system. On the reimbursement side, I'll take the first stab, but I want to choose my words carefully. I think it depends on the payer mix of a particular institution on how they're able to cover their cost of care. So you have different payers. You have commercial type payers, you have government type payers, and depending on institution's specific mix, it can be difficult for them to cover the costs of care for their patient population. And so while I do think there could be some, like there's truth in all the arguments, I would have more questions than answers for you, honestly, on that statement. That's all.
Right. In addition to that, every hospital system has a different cost structure. So what we hear the same argument or the same statement that you made, Omid.
Okay, John's checking his edits. Very quickly, Chair McDermott, I just want to acknowledge the unfortunate incident that just happened. It's taken a bit to, we've had a couple of different options related to how to have different security of meetings. We tried to make the version as public facing, member friendly as possible, but we will be permanently shifting how we do things. Our ideal state will be how the legislature does their process, which is promoting specific people to panelist status, and only those people will be able to speak. As we get into public comment, then we would elevate individuals from the public being able to speak, and we would use the same panelist process. Fortunately, many of our standard stakeholders who attend our board meetings are familiar with that process, so they should anticipate that that's the direction we're heading. It'll be a little bit bumpier today, but we'll get some things smoothed out, especially by the next SEB board meeting. We'll do our best for PEP next week.
Cool. I appreciate staff's ability to pivot on such short notice. Sky, thank you for coming down and being our savior here. You're awesome. All right. We were in the middle of I don't think anyone remembers what the last question was, what we were talking about. So John, maybe back to you for a fresh question and we'll just sort of jump back into it. Okay. John is attempting to use rudimentary hand signals as he's wiping sweat off his brow. I think to tell us that he either can't hear us. Can you hear us?
No.
You can, okay, you can hear us. We're seeing that, but you can't speak.
Yeah, he can unmute. I can't unmute him.
Okay.
He has to do it. I can ask him to unmute.
Oh, whoa. You had it there. One more time. There you go.
Yeah.
All right.
Thank you. Yeah, it kept saying
Whoa.
not allowed to unmute. I was like, I didn't do it. I promise. Yeah, so actually one of the questions that Omid, the second part of his question, is a really good segue into one of our additional questions. So I'll try to shorten the rest of the questions and still get us through the most valuable parts of the discussion. And that's basically what dynamics in the provider negotiations have changed post-COVID and any insights or thoughts as to why that might have been happening. So I'll just open it up to the panelists to give us their insights there.
Be quick. I just have a couple. Everyone knows that terminations in double digits, consolidations have impacted that. There's staffing issues, nursing shortages, supplies are up 33%. The hospitals are, what's it, bad in the red? In the red. We know it. Profits margins are coming up, but not as fast. I think the terminations are coming. I think the providers are kind of getting over it also. In the last couple, we've been in a termination fight for the last 2 years, all the providers. And in the last two, they're like, oh, last time it was really shaky in the community. Let's get this done before the letters are done. So I think they're feeling the crunch too. Providers are also coming to us less interested in the value-based components of our agreements. I don't know if that's the same with both of you, because you have to earn that and it's a payment later. So they're wanting that money up front, which is increasing, bringing the double digits up. And then I think I would just like to say, these terminations in this environment is not unique to Washington or Alaska or Oregon. It is across the nation. So we're not alone in that as we sit here at the table, but also across the nation. So those are the things that have been a big significant change from my perspective.
I agree with that, especially the nationwide perspective. And also one effect of the pandemic was, hospitals offer different services, obviously, and those services come with their own embedded margins. So when you look at, your typical acute care, the margin might not be as large as the elective procedures that they do. And when certain states across the country mandated that they not perform elective procedures for a certain amount of time when the pandemic first hit, even though they were providing acute care services and much needed services during the COVID pandemic, during that time, the margins were very different for the hospitals. And now it's been a catch-up game for them. At least that's what we're hearing them tell us. So above and beyond just even the staffing shortages, they weren't able to cover all those costs because the profit-making centers weren't generating the revenue that it was for a certain period.
I have a question about that. It seemed like our agency had pumped out a lot of money into the provider community, ARPA funds that came through. So
Federal too.
yeah, so it just strikes me as, well, yes, they may have been making less margins. How do they counteract that argument where they say, hey, we got smaller margins because we were only doing acute care, we couldn't do elective procedures during the time frame, and now we need to do catch up? It's like, where in the conversation is how much federal money did you get during the period, and how does that work?
So that was especially in New York, we had some of the hospitals got the largest payments in the country, New York Presbyterian and the like, and the response generally during that time was nowhere near enough.
I've heard that too. In addition to that, I think the labor issues compounded it quite a bit because there were labor shortages in the COVID period. Temporary staffing was brought in to support the acute care side, which also came at a premium price. And making up for that had been something that was difficult or has been difficult for the facilities and still is in some cases. We're just now in 24, we're hearing, okay, certain hospital systems are no longer going to be using temporary staffing and things like that. So they're just now starting to come away from that. As Kaiser Permanente, we're an integrated system. So we feel the effects of labor just like we feel the effects of having to change how we do business during a pandemic. And So I can say that that's real. It is something that was real and felt by all health systems. And you know, they did get federal funding in, folks did get some funding in. But we are hearing the same thing. It didn't necessarily cover 100% of what would have been needed. And then it backlogs grew as a result. So we also had not just labor issues, but capacity concerns as these elective procedures started to come back. And so folks are still trying to pick up for that. I think that some of that has gone away over the last year or two, but we're still hearing that at the negotiating table as we're meeting with our hospital partner.
And I think some of that I had heard was the bonuses they were giving nurses, traveling nurses, they were giving them bonuses to work at their facilities. The hourly rate was higher, everything was higher, and there was incentive payments to stay. And so there was a bidding war going on for these individuals throughout the country to try and draw them to their local area.
Has to keep the lights on.
Yep.
Yeah.
So
Well, and the nursing unions too. They came full force and there was huge increases given to the unions. They lobby for that. One thing I would add too is that we're finding providers are dropping, I thought you were gonna allude to this, but dropping services that aren't lucrative, right? Like BM just gave up giving up having babies in King County. Because it's costs them more than it does to, you know, get reimbursed for it. So, and like a big system can have multiple, let's say, Medicare Advantage contracts, one with Primera, one with Regents, one with, right? And they are consolidating those, saying, I want the top two best Medicare Advantage performers we're gonna have a contract with, we're gonna terminate the rest. And that's just one segment, right? So they're dropping services and dropping contracts by line of business that are not lucrative. I mean, Medicaid and Medicare are increasing in the state, so the commercial payers subsidize that through these contracts.
with the increases that the nurses got through the unions, were those permanent increases or so those are just,
They were like 22%.
and those are just built into the system now?
Right.
Understood.
You go off mute, John?
John, you're off mute, but you're either messing with us and pretending like to talk, or you're trying to talk and it's not happening.
He's on mute. There you go.
There we
There you go.
I made the mistake of muting so I could cough, and then I couldn't get back unmuted. So I think in the last couple of minutes, the one thing that I'd like to get us all focused on and addressing is the economist in me and the debate team member in me would say everybody loses with the member stuck in the middle of these when there's a mass termination notice, right? Payers have concerns about that, I think, because it disrupts their relationship with the member. The providers would also, you would think, from having some stickiness with those members, would see a downside to communicating mass termination notices as part of a negotiation strategy. And certainly we as employer groups see a downside to it, and the member, of course. So any thoughts as to what might be on the horizon or things we could do to change that dynamic so that that becomes less of a appealing approach for a standard negotiating strategy?
No, I would say, you know, I know the OIC regulates the health plans, but you know, holding us the entire ecosystem of the community to the same timeframes of notification would eliminate some of the confusion. It's unfortunate if it does have to get to that point, or it does have to happen, but members do have a right to know about their continuity care benefits, and not if a contract or provider is leaving the system. And it's not just the mass ones, right? There are PCPs that sometimes come and go, and other smaller providers, but making sure that together we're messaging this at the same time similarly, I think would help a lot and become less of a weapon and a leverage point in negotiation. Just a thought.
I think that would have to be legislated. There'd have to be some rules around the provider and syncing that up. and what kind of communications can be out.
I agree with that.
Okay, well, I know we're right at time. So again, I want to thank the three of you for your time today and your engagement with the board. This, I think, or I hope, has been a really helpful, insightful conversation, which I believe it has for all of us. And just appreciate the effort. Yeah.
I want to let you know that because of the delay, we're going to go ahead and start the next presentation at 10:45. So we have a little extra time. So if you've got more cards up your sleeve, feel free to ask.
Yeah, I think the other was around, it's kind of a dovetail off of that last question that I posed. What changes are there from product design, from alternative payment methodologies that would more closely potentially align payer and provider interests and not want members being stuck in the middle and receiving term notifications, that it would be more about attracting those members and being as engaged with those members as possible. So any developments you're seeing in the provider space or the contracting space that might help with that?
I would say, I mentioned that our traditional value-based agreements that we've had in place for years, 10, 15 years, we call them global outcomes contracts. There's less appetite for those, but the providers, I think, are interested in more risk-based, value-based agreements where they really have a high potential to win on the back end and not stuck, to attribution, which means, you have to have X amount of members for the data to be viable, enough to validate whether the contract or the provider's doing a great win-lose on the metrics, quality metrics they have. So we're looking at different kind of programs that are smaller, that can go with smaller groups, larger groups, and we're working with the providers to do that, to get their feedback on what they're really interested in, other than the traditional value-based we've had for years.
I agree with that. I think that the joint development of the programs is what is going to drive the better relationships with the providers, which leads to, I think, at the end of the day, a more amicable negotiation and less chance of termination at the end. And so part of the development of these programs, some small, some larger, is really about the development of the relationship in a different way, to ensure that the plan and the provider are working together in concert to take care and manage our patients together, because they are ours. And in doing so, we just create a bit more synergy when it comes time to renegotiate the agreement. It's not that we haven't talked to each other in 3 years, it's that we're talking to each other, every quarter or once a month or in whatever cadence, so that we do have that relationship established ahead of time.
I would agree. And also when you start talking about risk or other types of reimbursement or payment relationship models, you look for administrative in those types of agreements too, right? Some things become less important when you're not on a fee for service, right? A member goes in, you pay for that visit instead of paying for that member's, the entirety of the cost of care. Things like prior authorization, when providers have what we would call skin in the game, right, for a term, or they were a real opportunity to earn based on making sure that members are getting the right care at the right time, the right setting, it's appropriate, and they're considering, that whole episode of care, and they have an opportunity to create some savings in the system and earn off of those. Those administrative requirements become a little less important because they understand they're doing the right thing and they're doing what they need to do. Outside of doing that in a risk arrangement, we've created some partnerships with certain providers like Multicare, where we've embedded our prior authorization workflow within their electronic medical records. And so we're scaling those types of efficiencies with providers where they can just go in, they click, they know what you need, We have access right into the record. We can see this is appropriate care, where it's being done is appropriate. This is the next step in the episode of the treatment plan, and it gets approved immediately. It makes for a much better member experience, and it's much easier for the provider rather than waiting a few days to get a response on a prior authorization. So it's those types of conversations that having with providers that it needs for slightly easy. It's never easy talking about money, trust me, but like it leads for at least an easier path to have that conversation because you're finding efficiencies within the business with each other. So.
And then thanks, I appreciate that. And I want to back up and pick up one piece that we glossed over earlier, and that is there's been a lot of discussion nationally and locally about pricing transparency, and that as pricing transparency increases, there's intended and unintended consequences on provider rates. With the work that's been done in the state of Washington in particular, I'm curious if you're seeing any impacts on the contract negotiations due to pricing transparency in Washington state.
Yes, so price transparency, it's one of my actual favorite topics to talk about because I think in theory, it's a good thought, right? Consumers can go out and they can see what it's going to cost for certain services. And the better price option would become where patients are attracted to and they would go. What we've seen in practice, though, between low compliance and just the complexity of what's actually behind that pricing, it's not very consumer friendly to use. People have a hard time understanding CT scan of the orbit and like knowing like what do I look up, what am I looking for when they're looking at the hospital or the provider's price transparency. It needs to be a little bit easier to use. So what it's actually done is providers who have the ability to use consultants or other types of firms to take down the files and dig deep into them, come to us during negotiations and saying, we want to be paid the same rate as so-and-so. It's never the lower so-and-so, it's always the person who's paid the highest so-and-so. So in practice, it's become more of a race to the top. Rather than let's be competitive in the market to attract the members to get the care, which I think in theory is what was meant to happen.
Like you were reading my notes. Race to the top. So it is an unintended consequence where the payers can see the rates they have. I mean, there's something to be said about competition, right? Like do better, you get better, that type of thing. So our theory is everybody's racing to the top for parity, so everybody's going to get paid the same. They're even saying, now they're not even saying I want to get paid the same as this. They all want to be paid the same, and they all want to be paid the same up here. Which also the next step in that is they turn the leverage. They get all of the leverage in the negotiation. So they're like, everybody's getting paid the same. Everybody knows it. So, Mira, what are you doing better for me administratively than Regents is? Because if you're not giving me I can't go do my prior auth inside of my EMR and I have to go through your fax process. We don't really like you. And they're really talking about dropping contracts and really working closer with payers to really get rid of all of the extra contracts that they have that they're just doing for the community. Those are my words. But it's really a race to the top. It's going to be more expensive and there's probably going to be less action. That's my prediction. Again, only. I speak for no one else. That statement.
I think that's spot on. It is a race to the top and we're all feeling that and experiencing that again at the negotiation table. At the same time, I think earlier I was saying that the cost structures are different. So a cost structure at one hospital system would be very different than at another. So we really do have to be thoughtful as we're speaking to these providers about what they are providing, how they're providing it, and what that leverage actually is. That is an interesting conversation in our work. But it is something that we are faced with as providers are looking to get the top dollar and think they deserve the top dollar.
So any other thoughts about what we should be thinking about collectively to try to both right size, or maybe right size is not the right term, but control healthcare costs, which are increasingly large, and improve the member experience related to the contracting negotiations, provider negotiations, moving forward? Just be curious, any of your thoughts in these last few minutes?
Yes, I would say, speaking of unintended consequences, so when you put priced fixing on a certain line of business, and I'm not saying I'm for or against, I get the whole floor and ceiling concept. So when that type of arrangement happens, like for SEBB, we're gonna, providers are gonna get a certain preference-based pricing. That's the right term I think you're using. I'm totally for that. I get that. What will happen is just the balloon will squeeze, and the other markets, the other commercial, will have to pay more to others to ratchet those rates down. They're not going to take that rate and just walk away and say, okay, this is what it is now. They're going to come to all of us and say, now I need more on your federal business. I need more on your commercial business. I need more on your business. So I would just say it's a good thing to have happen to lower the costs. It just may lower the cost for one segment.
And we just received a proposal recently that looked just like that. There was a balloon on the end. So it's imperfect. It's an imperfect solution, I think, because we are, this is Alicia's opinion only, but I think it is an imperfect solution because the total cost still goes up. But now it's just going up for a particular segment, and still we have disparity between the commercial.
So again, the economist in me then goes to, you set the rates, right? That's the solution if that's the problem we're facing collectively. I'm not suggesting that that's the solution here. I'm just saying that in some manner, we have to get to a method that controls the costs and protects members' access, right? And we haven't talked at all during this conversation about equitable access and equitable outcomes, which I think is another important piece that often gets overlooked. But I keep going back to one of my questions, which was what new product design or alternative payment methodologies might be part of that solution that aligns the provider's interests with the member's interests, with the payer's interests. And so that would be my challenge here, right, to all of us, to be thinking about what those designs might look like that would start to align the outcome of financial outcomes for all of the various parties. And that's, again, from an economic standpoint, that's pie in the sky, right? You're never going to have everybody a model that everyone thinks is the best thing since sliced bread. But moving in that direction, I think, is part of what I would challenge us all to be thinking about. And I see we've got some questions in the audience, so let's take some time for those, please.
Go ahead, Allison. You just need to unmute yourself.
There we go. Thanks so much for that comment, John. I think that is one of the areas of interest and exploration I have is really around the equitable care. And I think when we sit too far into a fee for service model, it focuses us on more volume. And in a value-based environment, I can see the resistance of providers wanting to ensure they have adequate payment in order to sustain their operations. And coming from an area that is predominantly rural, once you get outside of downtown Spokane, this idea around how long you should have to travel to be able to get to care that is both culturally relevant for you and allows you to meet all of those standards. And it does feel to me that while I think for years we have been trying to move the needle on the financial side of this, that there is some important room for innovation in how those payment models would look. So mostly just want to put an exclamation point on that and some appreciation around specifically calling out the equitable portion of access and care that is culturally reflective of the community.
You, Allison.
John, just giving you a little time hint. We're about 4 minutes out.
Yep. And so I was just going to close it as I was inappropriately doing before, with thanking our panelists for their time today. I really appreciate the engagement and being there on site. Apologize that I'm not there with you again. But I think this has been a good, informative discussion with the board, and I hope that folks found value in it. Hopefully, we'll continue to have some ongoing conversations, and we can look at maybe some follow-ups from what was discussed today throughout the board season. So more to come on that front. And then, barring any other questions, I will turn it back over to you, Chair McDermott.
All right, thanks, John. I appreciate you guys coming today and doing your thing, and really sorry about the interruption. You at least have a story to tell when you get back. So, a little bit wild. Yeah. So,
Thanks for having us.
thank you so much for your patience and all the information. Appreciate it.
Yeah, thank you.
All right, next up, we have Robin Williams. She is the interim budget director for the Office of Financial Management, and she's going to provide us with a little update on the state budget. Her materials are behind tab number 3. Robin, welcome.
Thank you. Yeah, I heard I missed some excitement.
You missed a little fun. So, and by
This will
fun,
be
I mean
less-
the horrible things were said and shown.
I've heard. This will hopefully be interesting, but probably
Less
a
shocking.
little less surprising. If you're paying attention, but it is. So should I just jump in?
Yes, and people are either the board can rate. We normally say wait till the end to raise their hand, but it's up to you. If you want to hear questions along the way, you can put their hand up, or a board member can indicate by hitting their button.
Okay.
However you sort of want to do it.
Okay. Yeah, I think if people have questions, that's fine. And there may be points where I'd say, I'm actually going to get to that. So
Perfect.
we'll just kick it off. Yeah, as Lou said, I'm the interim budget director at the Office of Financial Management. I tend to speak quickly, so sorry. We are the group that puts together the governor's budget in the fall, and I've been the deputy budget director, so I've been there for 9 years. So I have a little bit of experience. Today, the purpose of me being here is to kind of give you context on this upcoming biennial budget. If you've seen the news, the context is not, this is a spoiler, it's not great. The revenue forecast, I'll talk about the revenue forecast and updates, talk about what the governor and then is required to do and how that compares to the legislature. And then I will cover a bit of what's in, not really what the substance of what is in, I don't know what's happening here, in the Governor Inslee's proposed budget, but and then I will also compare that to what Governor Ferguson has conveyed as priorities. And then the last thing I'll talk about is the timeline, like where we're at in all of this. So let's just get into it. So the first thing to talk about here is the revenue for the state. Like when we talk about general fund or near general fund, we're talking about the revenue that the state budget must balance against. So it is set forward by the Economic and Revenue Forecast Council, which interestingly, their last meeting was also hacked. But it sounds like a little bit different content, but also great. So they're the official state forecaster. They have quarterly forecasts of the near general fund revenue. And when I say near general fund, I mean general fund is like the big pot, where your taxes go into, the sales tax and whatnot go into. And then there are some other accounts that are also very flexible. So that's what we're talking about is near general fund. The state funds that are are the most flexible. And they have to balance again. They have to, they're part of what we call the outlook. And I'll continue to get into that. So they forecast the near general fund for the current, biennium that we're in. Right now, we're in the last fiscal year of the 23-25 biennium. The budget that the governor proposed in December is for 25-27. So they forecast the revenue for that biennium, and then also for the 27-29 biennium, which is the outlook, which is 2 years beyond. So usually we're talking about 4 years, but because we're in the last fiscal year of a biennium, it's a 5-year forecast right now. And then so together, as the bullet says, together with the reserves from the previous biennium, which just means what was not appropriated. So what general fund there was available for the legislature to appropriate, but they didn't. So like your monthly paycheck, if you have money left over, that's your reserve that you could use the next year or the next month, whatever. And then so you add that plus the forecast for changes, and that's what you get as the base revenue available to be spent. So that's the kind of primer on revenue. As I said, there are quarterly forecasts. The last forecast was in November. The next one will be in March. And then they do monthly updates. So the November forecast, which is the one that the Governor Inslee had to use for his proposed budget, it was downward compared to February, which is or March, which was what the enacted budget used. So you can see the dollars are large, but percentage wise, it's we might say that's almost flat because it's less than 1%, but not less than 1% upwards, less than 1% downward. So less money to use for this fiscal year and going forward. And the factors that they use, they look at the unemployment rate. They look at international things like international conflicts, oil prices. They use the CPI, Consumer Price Index. They look at national GDP, things like that, state GDP, exports. They considered in November, they considered potential tariff impacts and monetary policy such as interest rate changes. And that's what they use to come up with their forecast. As I mentioned, retail sales tax is kind of the one that we all pay to contribute to the general fund. So it's the largest part of the general fund. Then the next biggest bucket is business B&O tax, but business and occupation tax paid for by businesses and people who do services, things like that. Many of us also pay for property tax, and then there is other, which includes liquor sales, I think marijuana, some what we used to call sin taxes, tobacco, capital gains, and insurance premiums. And then the real estate excise tax, that is essentially like sales tax, but for real estate transaction. So that's what goes into the near general fund currently. Did you skip a slide? Okay. The next one, yeah, there we go. The majority of near general fund spending is required. So if you can see, you see that pie chart, the red or pink portion of it, that is 65% of the budget. It's protected by law, meaning it's either in the Constitution or it's an entitlement. So debt service, that state is required to pay to cover our debts. That's in the Constitution, and we are required to pay to contribute to pension funds for state employees. Entitlements are things like Medicaid, basic education, TANF, which is cash assistance. Those are things that the state is required to do. If you meet those, if you qualify, if you are a third grader, the state is required to pay for your basic education. And if you qualify for Medicaid, similarly, the state is required to pay for your Medicaid bills. Correctional institutions are considered required because if you are sentenced to a prison, the state is obligated to care for you. The working family tax credit, that's a newer entitlement. We're required to pay for the courts, and then transfers to the budget stabilization account. Each enacted budget requires, I believe it's a 1%. I think it's 1% transfer to the basic budget stabilization account, which is sometimes referred to as a rainy day account.
Robin, I have a question.
Sure.
Would the PEB and SEB program, because the collective bargaining and other impacts, are those considered in the required pile, or are they considered in the optional, or a little of both?
Yeah, it's a little of both. So what I would say is, and this is how I have done these presentations during bargaining as well to different tables and interest arbitration. And the way I've explained it before is, if you're a state employee who works in a prison, and your collective bargaining agreement that you are working under currently, or your PEB agreement that you are working at, you use currently, that's been enacted by the legislature, that would fall into the required. If you are somebody who does, I'm going to pick the natural resources bucket in the not required spending. If you're somebody who goes out and tests water in the streams, which I'm guessing is a job, that is, it's same caveats. Your current PEB and your current collective bargaining agreement, it's required in that you either pass the collective, if the collective bargaining agreement is funded, it's a little complicated, is my point. But like, it's easier to cut that person the jobs for people who do things in the blue column, blue or the right not required column. It's so
it's more driven by function.
It's more driven by function.
If you're doing an optional function, then all the things associated are required if that function is being paid for.
Yeah.
If the function were to go away, then it's no longer required to provide you with ongoing health care and all that.
Right, exactly. And if the collective bargaining agreement is funded by the legislature, it's the current thing that you're working on. It's not the proposed one that is being bargained or is contemplated being changed until it's passed by the legislature. So that's how I would describe it. Other examples of not required spending, there's a lot of human services that you kind of think of as basic, like public health, some state-only funded healthcare programs for people who don't qualify for Medicaid, or and similar programs for people who don't qualify for other federal programs. Higher ed is not required. It's a large chunk of optional stuff that we, potentially value and keep funding. And there's some non-basic ed parts of K-12, like grants and things like that are not required. And similarly, like general government, state basic operating costs, there's nothing by law that requires us to have, I don't want to pick on anything, maybe like a state auditor or, like the really good things.
The healthcare authority.
The healthcare authority, yeah.
Here.
Yeah. So it's not as, other than Medicaid. And then reserves are not required. And so reserves, you know, meaning the like part that the legislature didn't spend of their available revenue. However, I would say both the budget stabilization account and the reserves are really looked favorably upon by our bond rating entities, which we need. You know, we have a high bond rating, high being good, and that is important in terms of when we need to, you know, issue bonds and basically borrow money to pay for buildings and whatnot. So not required, reserves not required, but they're really they're a good idea. So this is just a little primer on what goes in, how our budgets are built. So we start with the prior year by enacted budget, and then we do a process called carry forward level, which is basically saying, you know, truing up something that was funded by the legislature, if like it was a partial year was funded, but now we need the full year's worth of funding for the agency to do that, to continue that thing. That's carry forward level, where we put in that the rest of the year. Or if something was funded for one time, you got to take it out in the future. Maintenance level.
Robin, I'll just add a quick example. Tanya often brings to you and says, there's 6 months of this built into the budget, and then the reason the number gets larger in the future is because it counts per year. That's the exact concept Robin was describing.
Yeah. The maintenance level is the new cost of current projects. So using Medicaid as an example, it's the new cost, you know, if hospital rates went up, or the, you know, as drug costs always go down, I'm being sarcastic, it would be a reduction if that happens ever.
Sometimes things go generic.
Yeah, so it's based on current appropriations, and it's just changed. And a large driver at maintenance level is caseloads, especially in the K-12 area. So that is a big driver. Caseloads are for things that we consider entitlements or we treat like entitlements. It's like the Economic and Revenue Forecast Council. There's the Caseload Forecast Council. They do 3 forecasts a year, and they forecast the utilization of state entitlement programs such as the public schools, adoption support, offender institutions such as prison, caseloads, foster care, Medicaid, big one. So yeah, and working family tax credits, and they were one there. So that's that they set the caseloads, and then during the governor's budget we put the equivalent costs in, cost changes, and similarly, so it's the same sort of timing that there's a November caseload forecast that the governor includes in his budget, and then there'll be one in February for the legislature. This is to show you how broadly how the New York General Fund state breaks across the or is distributed across the budget. This is from the 23-25 operating appropriations, so it's not based on the governor's budget, is my caveat here. But K-12, you can see the big spender out of the New York General Fund. It's 43%. It's the state's paramount duty in the Constitution. Human Services there is the next bigger spender at 36%. If this was total funds, I think probably Human Services would be bigger because there's all this federal money. Higher ed is in the green wedge. It's 8%, and then we move into general government, which would so higher ed includes the 4 years and all the community colleges, as well as some scholarships. And then general government includes, the insurance commissioner and a lot of the the Secretary of State's office, the Department of Enterprise Services, who does like renting space for the state agencies. that sort of function. Natural resources is 1%, and that would include, you know, Department of Natural Resources and Fish and Wildlife and Agriculture, et cetera. And other there includes debt service, pension contributions. There's a couple transportation agencies that have budgets in the operating budget, like State Patrol and Department of Licensing. And then there's some special appropriations that are in the other bucket there. And I didn't give example of human services, but it's Department of Social and Health Services and HCA and Department of Children, Youth and Families and Department of Corrections are the big ones, and then Department of Health, et cetera. And now we are to the operating budget framework that from Governor Inslee's budget. You can see at the top, there was a beginning balance of near general fund. That would be reserves, basically. And then there's forecasted revenue. So we're looking at, you know, available revenue of about, you know, 70 something million for the three different biennial budgets that we're talking about. And then so that's basically like your spending, your salary, if you will. And then the appropriations included in Governor Inslee's budget. So for the base part that I talked about, the carry forward, what was already enacted at maintenance level, that you can see that eats up a lot of the available revenue. And then you add in anything that Governor Inslee proposed, which would be, we would call policy level, but that's basically just new funding or continuing funding of something that the legislature considered one time or things like that. That's a very modest amount. It looks like a lot, you know, 0.2 billion in the next, for each of the next two biennium, but that is much smaller than typically proposed in a biennial budget because of the size of maintenance level in particular. And then the reductions, you can see the red line there. You may have heard that Governor Inslee proposed $2 billion worth in reductions of things like, you know, funding that wasn't going to be spent. You know, that he proposed a couple facility closures in both in Department of Social and Health Services and Department of Corrections. Some reductions in utilization of some other facilities, and just some other, you know, other things that added up to about 2 billion. And so you can see the revenue minus appropriations there. The governor is required to submit a balanced budget, meaning it can't be in the red. And so without any other revenue, this, you know, he would have, you know, this, you couldn't submit this, the governor couldn't submit this as his own budget proposal without proposing revenue or making more reductions. And as you may all know, he proposed a revenue package. And I think if we go to the next slide, it will have some details on that. Oh, no, I forgot. So I will get to the revenue, don't worry. This is just an FYI because I thought you all would be interested in the collective bargaining compensation, you know, things that were collectively bargained or there's some things that are not exactly collective bargaining, but are similar, like consumer direct employer, that are we would consider compensation related. SEB and SEB look odd because they look like reductions, and my understanding, and Dave, I'm gonna look to you to help me out here, is that is more of a how we're counting something rather than a full reduction.
Yeah, Tanya will go over this a little bit later in her presentation, but there are some additional reserves related to the long-term disability benefit, the employer paid benefit. Essentially, we've had more favorable claims experience over the recent years. And so there are some buildup in the funds that have been supported by the state dollars for that employer paid benefit. And this is a one-time transfer back to the general fund, reducing the reserve levels that are out in those accounts. There are still mandatory reserves, so it's not, you know, completely zeroing out those reserves, but it is doing fund transfers back. So Tanya will talk a little bit more about that, but these are really one-time LPD reserve transfers.
Okay. And then go to the next slide. Okay, so you can see the top here is the Governor Inslee's proposal, included $2 billion of reductions, as I mentioned. The new appropriations, that 40% of past budgets, that's the line where I said that's very low. New policy items, it was, I think it was like 2 billion in each of the next 2 biennium. That's 40% compared to like 2 years ago, the budget he might have submitted and so biennial budgets basically. So basically he didn't propose much that was, instead this budget is mostly funding just new costs of current government functions. He did include or propose new revenue. There's a few different things, but they total up to $13 billion in new revenue, which is how we, that, and there was a proposal around merging the left, which is law enforcement officers and firefighters, their pension. That's a little technical, but anyhow, that contributed to some additional available general fund to spend. But that's basically how the budget balances, is this revenue project, the base revenue proposal.
And I'm sorry if you said that. Is this for the 2-year budget for the biennium, or is this the 4-year outlook?
4-year, 13 billion is 4-year. So is the 2 billion number in reductions, that's a 4-year, 5-year number. And then the governor, I think in November, maybe, probably November, issued a freeze for hiring, for state agencies for hiring, contracts, equipment purchases, and travel. So, and those are still ongoing. We're still operating under those. So there could be additional savings related to those items. In contrast, Governor Ferguson has outlined in his priorities that his target is an additional 4 billion of savings, which is on top of the 2 billion. So it would be 6 billion total. And he has some strategies that he recommends. The savings targets are 6% for most agencies, including HCA, and 3% for 4-year higher eds. There are some agencies that are excluded that do deal with public safety, and community colleges are excluded from this activity. And basic ed is also excluded. But otherwise, it's a large target for agencies. And the strategies that he's requesting that agencies look at it, constricting management, like consolidating management, reduction in travel, and there's some targets on all of these, and equipment purchases, suspend legislative reports, and then he's got some suggestions around how to reevaluate programs, including looking at new programs that were funded with federal money, like COVID money, that we're now funding with general fund state, and looking at programs that don't serve a lot of people, and things that have been a pilot, and whether newer programs and whether those should continue. Essentially, Governor Ferguson has identified his priorities as as I mentioned, public safety. So increase grants for local law enforcement. He wants to fund the toxicology backlog to get that processed. He's continued to address housing and homelessness. Ferries are a priority. He is interested in having universal free school lunches. And then one of the things in Governor Inslee's budget that I want to touch on here to explain the childcare thing is, there is a program for low-income workers can qualify for childcare, and right now it's available to people who are at, I think, like 65% of the state median income, and by law it's set to increase eligibility. And in Governor Inslee's, budget, he proposes delaying that increase eligibility because it's quite expensive. And Governor Ferguson is proposing that we increase it for people who work for small business. So not for everyone, but a targeted for people who work in small businesses, increase the eligibility, I think up to 75% of state median income. And then Governor Ferguson has indicated that he is not interested in new revenue. His words have been only as a last resort. So basically, typically we say, or we might acknowledge that the governor's budget has been historically in the last few years the high watermark. Usually the legislative budget is not as big, basically. And so, you know, if the governor is less interested in 13 billion in revenue and the caseloads haven't changed dramatically from November and revenue hasn't suddenly shot up, you know, $4 billion in reductions will help, but you know, we'll see what the legislature enacts and what gets passed. But I imagine we're talking about a smaller budget than Governor Inslee proposed. And where we are in the timeline, as I mentioned, Governor Inslee's proposal was based on the November caseload and revenue forecasts. The governor proposed his proposal is he's required to make it by December 20th, and he put out his budget on December 17th. The legislature convened last week, so we're in legislative session, and they are the appropriators, so they will, you know, put forward their own budget and pass that at some point. But their caseload forecast will be in February, and their revenue forecast will be based on March. Will be put out in March, and so they'll be required to use the March revenue projections in the same way that the governor was required to use November. And then at this point, the official legislative session will end April 27th, unless it doesn't. And then and at the end of session, the governor has 20 days to review most bills, which includes the budget, and he will. So he'll likely have to sign, assuming that the budget passes around the 27th. He would have until May 20th to sign the budget and or veto parts of it. That's the overview there.
Do we have any questions for Robin?
Couple of things I just wanted to highlight. You know, every year Tanya brings forward information about the various budget proposals, and at the very last slide where the legislature has to rely on the Revenue Forecast Council in March as to why we don't see budgets until March in a long session.
Yeah,
because that's a structural design that always happens. That's why there's not more information or more budget proposals to bring forward. One of the other reasons that we wanted Robin to come today and share this context is I know that you as board members often you see letters that are directed to the board that we package and send to you, but you also get some direct advocacy, and many times those consumer constituent letters are about asking for benefit enhancements. Some of the most recent ones are ones that people care deeply about for a variety of reasons. Many people in this room as well, many of you, many of our members, many people in government, things like fertility benefits, weight loss drug coverage. There are various pieces that are of high interest to many people. And this agency produces fiscal notes and does analytics about what the cost could be, but the vast majority of enhancement by definition come with an increased cost somewhere. And that is going to be very hard in the future coming biennium, foreseeable ones, to balance those types of requests with the fiscal realities of the state. And we wanted to be able to ground that conversation with the board for the next couple of years, be able to kind of point back to this and remind people of the bigger context in which these programs work for state government. So that was just another key piece to highlight for everyone.
Anything from the board? Robin, thank you so much. Appreciate you taking the time, coming down, being with us.
Good to be here.
Have a good day.
Thank you.
Melissa Richards.
She's remote.
Oh, she is remote. Alyssa, how you doing today? Let's see you get off mute. Give that a shot. Yeah. Look at you. Awesome. All right.
I can
Alyssa
click
Richard.
Buttons.
There you go. Alyssa Richards, our benefits account section manager in ERB, is going to present the agency's efforts during and the results of the SEB program plan year 2025 open enrollment. Materials behind tab number 4. Alyssa, you're up.
All right, thank you. Good morning, Chair McDermott and members of the board. For the record, my name is Alyssa Richards and I'm the Benefits Account Section Manager, and I'm going to be giving you a brief overview of how open enrollment went this year. So next slide, please. So there are 2 primary units involved in open enrollment activities in the benefits account section, which is our customer service area and then outreach and training. The customer service unit is the first line of contact for retirees and continuation coverage enrollees. And staff in our customer service unit perform 3 primary functions. They answer a toll-free line and respond to HCA support inquiries. They provide in-person lobby services for walk-in members, and then they review the members' retiree or continuation coverage eligibility as they process those enrollment forms that are received. So next slide, please. And then Outreach and Training Unit provides training and support to agencies and organizations for both the PEB and SEB programs, who in turn act as the first line of customer service for the employees. Outreach and Training provides training to the benefit administrators and regarding program plan options, covered benefits, eligibility rules, and enrollment processes. When these agencies or organizations need additional assistance, they will reach out directly to Outreach and Training through a dedicated toll-free line or send a secure online correspondence through our HCA support portal. And then the Outreach and Training Unit also supports the in-person benefits fairs across the state of Washington during open enrollment. Benefits fairs are scheduled in-person events where an employee or a retiree can learn more about their health plans and benefits, and dates, times, and locations are advertised in the October newsletters as well as on our HCA website. Next slide. The customer service and outreach and training units work with other HCA divisions on open enrollment activities year-round. Some examples are preparing the Benefits 24/7 online system, as well as our Pay One system for open enrollment readiness, which would include updating plans available by county, premium amounts, messaging, etc. The outreach and training unit secures vendors' locations and schedules for the in-person benefits fairs. And they also offer a pre-open enrollment training for benefit administrators in October to prepare them for open enrollment. We continue to work on the virtual benefits fairs. Virtual benefits fairs is an online website that's created with the same goal in mind as in-person benefits fairs. And some of the features are members can learn about their benefits from their home. It's available anytime, day or night, and it can be accessed via a computer, tablet, or smartphone. And that some carriers provide direct interactive webinars, pre-recorded webinars, and teleconferences to share plan-specific information. Next slide, please. So I want to provide some highlights for this year's open enrollment. The open enrollment dates were October 28th through November 25th. We did extend the date for members to submit a paper form until 11:59 p.m. on Wednesday, November 27th, due to the significant power outages that occurred throughout the state due to the storms the week of November 18th. We sent a message out about the extension to benefit administrators, posted to our HCA website, and we sent out an email communication to members who were signed up for email communications to notify them of the extension for submitting those paper forms. And members were also able to access the online Navia portal or submit a paper form for FSA and DCAP through November 27th. So they were able to keep their online system open. For that extension.
I wanted to give a little more context on that piece. People have asked, you might wonder, why would we be able to allow ongoing electronic enrollment for part of the benefits, but not the other part of the benefits? And some of that, this is like one of my least favorite phrases to say is system limitations, because it comes off very bureaucratic. But it is the reality here, and I'll give a little bit more context on it. So there are multiple file exchanges that have to happen between multiple systems to get to January 1st. And it might sound a little odd, but we've talked a little bit about the archaic part of the back end of our systems. It's from the late 1970s. It's not the public interface that the members or benefits administrators engage in, but it is kind of the backbone of much of our IT infrastructure. And so there are a lot of limits on how many times that button can be pushed, which days those buttons can be pushed. It's based on business days, not calendar days. So then when you get into the state holidays that happen between late November and early January, they're just, the number of days gets really truncated really fast. And the way we were needing to push things for both PEB and SEB this year, there literally wasn't an extra day in our timeline to give for benefits 24/7 for that system migrations to not begin that night. If they're able to be caught up on things that are keyed. So we had to balance that a little differently. But with Navia, their data gets migrated to us a little bit later into early December. And so we were able to have them keep their portal open. So we were trying to balance as best we could during that, the effect of a phrase I didn't know, bomb cyclone, existed until this year, and just try to navigate that for people a little bit better. So back to you, Alyssa.
And just to add, the Benefits 24/7 system was still available for benefit administrators to manually key in those open enrollment changes. So it was just the member-facing portion that we weren't able to have beyond the open enrollment end date. Let's see. So from the first day of open enrollment, October 28th, through the scheduled last day of open enrollment, there were 65,000 SEB subscribers who logged into their Benefits 24/7 account. And there was no downtime in Benefits 24/7. Clinton is here to give a presentation on Benefits 24/7 coming up shortly. So he'll have some more information on that. On October 28th and 29th, we did get some reports of intermittent SAW login issues, which were reported to WATEC. And WATEC is the agency that supports that Secure Access Washington portal. We also made the paper form available on our HCA website so that members could choose to make changes online through their Benefits 24/7 account or complete a paper form and return it to their benefit administrator. And then also wanted to highlight the outreach and training team received 1,574 HCA support requests from benefit administrators during open enrollment. So those were questions, requests for help in the system. So there were about 1,574 of those. Next slide, please. We continue to use member feedback for our benefits fair planning this year. We hosted 15 fairs across the state. The locations for this year's fairs were selected based on member enrollment data, and we also supported 4 fairs that were hosted by the University of Washington. We increased staffing at the fairs to help support the needs of our members. We started planning earlier for more of our program staff to attend so that they could help address member questions. Last year, we had some feedback about some lines at different tables for carriers, and so this was an attempt to help reduce that. This year, we also continued, as I mentioned, to offer the virtual benefits fairs, and we saw a significant increase in the number of visits to the virtual fairs. This year, there were 34,791 visits. Compared to last year, there were 10,813. As I mentioned on the previous slide, the virtual benefit fairs are available 24/7 and provide information from all plans. So next slide, please. On this slide, you can see the net changes for each plan. You can see the total number of enrollments by plan for 2024, which is a snapshot in October just before open enrollment begins. And then in the next column, you can see the final open enrollment results for each plan effective 1/1/2025 in the 2025 column. And then the totals in red in the change column are displaying a decrease in the plans, those specific plans. And some of them I think we were expecting based on service area changes. So for example, the Primera High PPO, there was a service area change as well as the Primera Standard PPO. So we would expect to see a slight decrease there as well. Next slide. On this slide, you can see the flow between plans. So you on the left-hand side is where an employee started in 2024, the plan that they started in. And then on the right side shows you the plan that they switched to for 2025. So I do have this graph filtered down to only show movement of 150 or more. Otherwise, it would be a big block of colors because many people, you could have one person change from one to another. So you can see, for example, there were 285 employees that switched from KP WA Core 1 to KP WA Core 2. You can also see 651 employees switched from Primera Standard PPO to UMP Achieve 1. 620 employees moved from UMP Achieve 1 to UMP Achieve 2. And 387 employees moved from UMP Achieve 2 to UMP Achieve 1. So I wanted to put some numbers on there for you. Next slide, please. And on this final slide, you can see a different view of movement based on the deductible being low, mid, or high. You can see from the chart that there were a total of 2,948 employees that were in a low deductible plan that switched during open enrollment. 824 went from one low deductible plan to another low deductible plan. And that's that top line across. 1,672 employees went from a low deductible plan to a mid deductible plan, as shown in the blue line. And 452 employees went from a low deductible plan to a high deductible plan. So it's just another way of looking at the changes that were made.
And
That is the.
This has highlighted a couple of ways to slice the data. We try not to do too many slices, but these are some things that we've historically provided. We're happy to bring the board other information about kind of some of the trends. Again, as Alyssa said on that, I call it the tube chart. She filtered it to kind of you see the forest instead of the trees a little bit, but just to show general trend and directionality of where members are migrating as a result of open enrollment. These are all things that will kind of get revisited as the finance team brings rates later during the rate development process. I think it's a good reminder, especially you don't have to flip back for electronic purposes, Alyssa, but on slide 7, just a reminder that the benchmark plan for purposes of the funding rate, the employee or medical contribution, kind of the core number that kind of then ripples through the finance process and the member premiums is UMP Achieve 2. And so that's the one where depending on kind of what the risk of the pooled risk for the members that are in that plan is what ultimately drives a lot of the financing and effects of that state contribution ultimately throughout things, throughout the entire rate process. So it's just an important one. That's you know, the way the financing model is set up, that is the line that gets the most attention because it drives the greatest cost long term. So we'll be diving into some more of the demographics of that, roughly $4,000 net shift into UMP Achieve 2 for the effects of that during the rate process.
Any additional questions? Oh, we have Donna.
Yeah, I have a question. When will we have enough demographic information to determine if it's classified or certificated moving within the lower and high deductible plans?
That's a great question, Donna. When I was just asking, are there other slices? We haven't done that slice before. We do have some challenges about how members are identified in the system, but we will take that under advisement as something to bring back or work on how to create that in the future for slicing and dicing data. Because I think that you're raising an important point about the salary level of part-time workers and how that is juxtaposed versus premium increases, and then the decision that result from that. So that's an excellent, I'll say, suggestion for how we bring things back / request.
Yes.
Other requests or comments? Seeing none, Alyssa, thank you so much. Appreciate it.
Thank you.
I think, Dave, am I correct? We're going to take a 15-minute break. Then we're going to come back to lunch and our presentation will be on benefits 24/7 update. I'll see if I can get Marianne down a little bit earlier.
Yeah, we're going to transition and lay out lunch and then be back for board members and the public, because the public can hear the benefits 24/7 presentation.
Perfect. Marianne Lindebath, the interim director here at HCA, has joined us for lunch, and we are going to go on to our next presentation, which is over benefits 24/7. Clinton Brooks, Herb Solution Architect in the Enterprise Technology Services Division, is going to join us today and give us an update. And his materials are on tab number 5. There you are, sir. In person. Okay.
Yeah. So for the record, I'm Clinton Brooks, Herb Solution Architect. And today for our presentation, we're going to go over at a high level what Benefits 24/7 is, get you some context around it. Then we're going to look at what the first year for the system entailed, the activities that we had. And then we'll look at enrollments, highlights from that. And then we'll look at the pain points that we've identified from the first year, followed up by the solutions that we're going to be pursuing as part of our roadmap this year to address those. The next slide, there we go. So what is Benefits 24/7? Benefits 24/7 is a centralized access point for members, BAs, and HERB staff to manage enrollment data. Benefits 24/7 replaces SEB My Account. Some of you may know that as SMA, and provides a digital platform for the PEP population. Previously, they'd just been using paper, and it is really the next step in the transformation of HERB from paper to digital processes. Structurally, Benefits 24/7 is really one of the parts of a two-system solution for managing the set of data. As you can see in the diagram and in the notes, Benefits 24/7 is the portion that the members, PAs, and HERB staff go in and they manage their data in there. And then every day, the changes that have been created that day are compiled into a file, which is then transmitted over to Pay1, which is our mainframe application, that then creates the file that is sent over to the carriers to update their records. The project that ended up creating Benefits 24/7 started back in the summer of 2020, and we actually just deployed the system last year in January. And then finally, wanted to note that Benefits 24/7 is currently supported by a team of 9, and Pay1 has its own separate support team. Next slide, please.
I think Clinton also just highlighting the visual is purposeful,
Yes.
because it shows Benefits 24/7 to the laptop. Pay1 is a bit older model, if you will.
Yes, just a bit. All right, and so the next slide is a visualization of kind of the different activities that we had over the course of this past year. Back in January of 2024, we had conversations about whether or not we should go live with Benefits 24/7. The decision was to go forward with that launch, but it was understood that open enrollment would be the real test of the system. Everything leading up to that would be kind of like a soft pilot. And so we went forward with that as our pattern. We did the initial cutover from SMA to Benefits 24/7, redirecting that set of users to Benefits 24/7, and there was no major issues in that transition. It was about 2 weeks later, though, that we identified that there were data migration issues which were showing up in the same process. And this was resulting in incorrect data being sent over to Pay1. And then, as it was supposed to, Pay1 was updating the accounts with that data. So once we'd identified that, Benefits 24/7 team moved really quick to put a stop to that. They put measures in place to prevent that from happening, manually corrected all the data inside Pay1. And part of the measures that were put in place we're tooling to make it so that we could manually review the records that were coming over that had any errors or discrepancies to make sure that we weren't going to have this sort of scenario happen again. Once we got through that go live period, we then transitioned into stabilization. For a large system delivery like this, stabilization is a common practice. And during that period of time, you typically focus on like defects, so things that aren't working correctly in the system, data fixes around how data is being entered into the system, maybe incorrectly, or in our case, also migration issues that we were seeing from Pay One, and then any sort of regular maintenance activities. The majority of our work during stabilization was around the defects and the data fixes I mentioned. As we were working our way through stabilization, the decision was made to go ahead and go forward with the delivery of Medicare Part D and Vision for open enrollment. Benefits 24/7 had already been designed to support Vision functionality, but there was a lack of capability to support Medicare Part D. So the team got started on doing any of the design and development work that was needed to actually deliver that. We also did carrier testing where we would send data over to the carriers to make sure that they could actually receive what we were going to send them with Medicare Part D and Vision. And then we also did operational activities to support open enrollment, like getting scripts together to default people into plans and set that sort of stuff up.
Briefly, Clinton, I just want to highlight Medicare Part D and Vision work had much more of an impact on the PEP population than on SEB. PEP transitioned effective 23 days ago to standalone vision products similar to how SEB is set up and has been since 2020. And so there were pieces and components for PEP to transition the population from an integrated vision plan into medical into standalone vision. The Medicare Part D is code for retirees, which you all know there is no retiree part of the population in our program. But earlier, many of you graduate, hopefully all of you graduate one day into retiree status. But the system work for those launches needed to occur alongside of additional stabilization efforts. But I did want you to say for both the public and you that that purple bar was much more of an impact on the PEP side of the house. You didn't miss some big proclamation.
Yeah, and so Medicare Part D did take a significant amount of effort from the team to deliver. So we were finding that we were doing more work on that side than on the stabilization side. So as we got closer to open enrollment, we had to do a slight pivot to be able to make sure that we could actually make open enrollment a success. And so that involved going through our backlog of bugs that we'd been identifying and selecting specific ones that were going to be high impact open enrollment and prioritizing the delivery of those. At the time we did go live, we also had delayed some functionality that wasn't critical to go live, but was going to be critical for open enrollment. And so we also expedited getting that portion of work done. We also did performance tuning within the system just to make sure that we'd actually be able to support the volume of users that we were going to see during open enrollment. And our initial pass at that performance tuning identified a 50 to 90% failure rate in some portions of the application that was principally used by benefits administrators. So we obviously invested more effort and time into doing development and testing on those pieces. We were able to get that failure rate down to a 0% failure rate with very minimal latency. Next slide, please. So open enrollment. So part of our open enrollment planning, we prioritize being able to open enrollment on time and close it on time. This is the first time that that's happened in 2 years for the SEB population. As Alyssa mentioned in her briefing, there was no downtime for the system, despite a large volume of users in the system and a pretty aggressive hotfix cadence that we were doing. We had no downtime to speak of. We saw a total of 127 unique subscribers access the system across PEB and SEB. 65,000 of those were SEB, and that was an 11% decrease from the previous year based on numbers we got from SEB My Account. And then for the SEB population, we saw a 78.2% completion rate on the open enrollment wizard. Just to give a little bit more context on that piece, completion in this context is referencing the fact that in Benefits 24/7, in the OE wizard, we have different milestones that we track for people as they go through that. And that's, you complete a set of screens, you complete a milestone. And this is really measuring how many people made it through to that final milestone and so completed the full process.
And the other thing that I want to add to the board is talking about the number of individuals individuals who were in the system at the same time. This was the first open enrollment where we had aligned open enrollment dates for the PEB and SEB programs as well. Previously, we had shifted them by about a week. The SEB program has always been on a schedule of the last Monday of October. The PEB program for decades has been on the calendar month of November, regardless of when November 30th falls. And sometimes November 30th falls on very challenging dates, like the calendar does this year, where Thanksgiving is as late as possible. But the 30th is on a weekend. And so effectively for the last 3 or 4 days of open enrollment, there is nobody around to support anybody because almost all public sector workers have holidays recognized at that time of the month. We have traditionally run into much higher volumes of appeals, much longer data migration issues. And so when the next time the calendar fell as it did this time, there was a purposeful shift to align the open enrollment. But what that meant is part of why we had kept them segmented is to make sure that any performance issues about the same volume, high volume of people being in the system at the same time, that we had done load testing, but at the same time it was we just always wanted to be mindful about roughly a third of all of our employees in both programs do their changes within the first 48 hours, another third do it in the last 48 hours, and the other third do it anytime between no matter how long open enrollment is or short, there's just this concentration at the beginning and end. So this was the first time where we had that high volume of the first day for both programs at the same time. And so there's lots of ways to slice and dice success and opportunities and failures. So that was a success. That was a successful part of it. That the load testing was the system was able to handle the load of both programs, high volume at the very beginning and end of them.
Let's go ahead and go to the next slide. Thank you. So we did have some fun the first 2 days of open enrollment. We actually had a partial SAW outage, and based on how SAW is set up, we weren't able to get precise numbers about how many people were impacted. But using the data that we do have access to, we project it was about 5% of users. And that would have looked like when they're trying to access the system, they may have had to try multiple times to actually be able to log in with SAW. So that was a definite challenge. We also had the team deliver a total of 10 hotfix releases over the course of open enrollment, averaging about 3.5 bugs per hotfix. Now, the interesting thing and the significant thing to note there is that those hotfixes didn't have any major breaking or systemic issues in them. It was largely things you would normally expect from a system launch or during kind of an open enrollment, troubleshooting people's accounts that got in a weird state, stuff like that. So that was also a significant point. And then finally, we successfully completed open enrollment and transmitted the data to the carriers as scheduled. We didn't have any significant issues with the sync process, and the vast majority of the data arrived over in the Pay1 system as we had expected it to. And then Pay1 was able to transmit all of that over to the carriers as scheduled. Next slide, please. So now I'm going to go through the pain points that we've identified for the first year. And just keep in mind that I'm going to also then, after we go through the pain points, talk through our approaches for addressing them. So the first major pain point was that the dependent and spousal portion of the open enrollment wizard was unintuitive for users. We got a lot of feedback around that. Many users thought they needed to re-upload documents for their dependents, which they didn't. And in some cases, we even had dependents or individuals connected to the user show up in the UI when they shouldn't have. The next major pain point in a functional domain was around long-term disability. LTD isn't actually a necessary part of the OE wizard, and its inclusion made it more complex and confusing for a number of our members. And then for the daily sync process, while in the majority of cases the sync is working correctly, it still does produce errors and data issues in edge cases. And an example of that would be the OE confirmation letters, which were sent out with 2024 plan information for some subscribers. Significant staff time is spent addressing these errors and cleaning up the data. And as you can expect, it is frustrating for members and BAs to see one set of information inside Benefits 24/7 and then have a completely different set of information communicated via Pay1 to the carriers. Next slide, please.
Real quick, Clinton, I was reflecting about earlier today. during our panel discussion how there was this reminder that we see these mass terminations occur, and they are very real and they're very challenging for many people when they occur. And also that there was the highlight of roughly 95% or more providers are on auto renewal, and that's just kind of running along. You can kind of think about that the same here with our sync process. If it's working for 95% of people, that's well over 200,000 individuals that everything is running smoothly for. But even a 1 or 2% error rate is 10, 12,000 people, and the challenges they get, the experience that those individuals have is very real. And so we have a very high volume of tickets coming in for benefits administrators. We're at roughly 2.5 times the volume of our normal standard what our staffing levels support. Our phone lines that support generally retirees have been averaging more in the 80 to 90-minute wait time range, which is far above our expected service levels. We always expect that it's going to be a bit longer in November and December, but then it starts to get back to more normal levels, and we're not seeing that downward trend yet. In our accounting team, they also are working on billing file issues that are escalated, and their volume is roughly, typically the staffing level has about 15 tickets at a time, and they're in the 120 range. So there's a really high volume of things that are working through the system. So while the system works well for a very large segment of the population, the pain that is felt for both the member, the benefits administrators, the staff here trying to navigate and get the enrollment right is very real and is the top priority for. That's what we mean by stabilization.
And one the bullet points I missed on the previous slide, we also saw around access issues, a significant number of calls and tickets coming in or around SAW and authentication questions in the application. And then operationally, what we did vet the system pre-OE with the IRF teams as well as the technical teams. We failed to include benefits administrators and members in validating the system. And we also identified, as we reflected on that there's no formal processes that currently exist within the development teams for being able to capture this type of feedback and include it in design assumptions that we're making or enhancements to the system. We also, because of the inclusion of Part D, failed to be able to complete stabilization to the degree that we would hope to have been able to complete it. And like Dave just referenced, that resulted in an increased number of support tickets and a slower resolution timeline for those tickets as we work to kind of balance all the competing priorities around that. And then finally, the team resources have been very stretched. The team put in significant work and produced exceptional results to be able to get us to this point, but they are extremely tired from the pace and the volume of the work that we've been doing. The next slide, please. So our 2025 roadmap and how we're addressing all those pain points. Principally, we're focusing on finishing out stabilization so that we can transition the application over to a maintenance and operation paradigm. And that's going to involve working through our backlog of bugs, that's data fixes and defects that we have to address. And then we're going to be prioritizing setting up some focus groups with EAs and members in order to make sure that we're getting effective feedback on the changes that we're making and establishing an ongoing cadence with those groups so that we can make sure that we're staying customer focused in what we're delivering. Around the SAW and identity portion, it's currently unclear to us what WADTEC's timeline is or their implementation approach for their SAW replacement. But it is clear what we currently are doing in the system is not really workable. And so we'll be working with WADTEC and other groups within HCA to identify options for being able to address this with the intent of being able to have a solution implemented before next OE. And then the team is planning to invest heavily into automation. A large majority of the work to support the system currently is manual, and that obviously introduces risks around resources and their availability, as well as just mistakes being made in the support of the system. And so the hope is that by investing in this automation, we're able to mitigate those risks and also reclaim some of the capacity within the team to enable us to take on additional work and further our goals. And then finally, should the decision package be approved that's being put forward, we'll be focusing on recruiting for 10 additional roles across the team. These roles would significantly increase the team's capacity and reduce our reliance on contractors. The initial focus for these recruitments is around testing so that we can improve our reliability and capability in that space. And getting those resources in is a critical part to being able to complete the stabilization of the system and transition over to a maintenance and operation structure. Next slide. Any questions?
There's probably some questions, but there's a few more context that I'd like to give everyone, and we can go back one more slide and just leave it on the 2025 roadmap. So a couple of things that I wanted to highlight are as we sit and talk about the challenges of the upcoming state budget. You know, I'm always one to look for silver linings, and I think people might know that about me at this point. So one good thing is that means there's not going to hopefully be huge substantial projects that suddenly we need to implement. And that allows us to keep our focus dedicated on stabilization. But even without those dynamics, I wanted to be clear about what kind of the IT main projects, if you will, because there are many things that could be on the to-do list for our systems. We probably have a backlog or a list of enhancements that have been generated either for benefits administrators, both at school districts or state agencies, as well as internally on things that could make the system better. And you can probably only imagine when you're talking about trying to improve a system that was built in the 1970s and still is the backbone, that there are many, many, many opportunities to make and streamline our processes. But first, we need to stabilize the system, and stabilizing it means making sure that the bugs that have been identified are resolved, that solving one issue doesn't generate another issue. And so, you know, stabilizing to the point where our customer service metrics on returning tickets in a timely manner, answering phones, speed to answer phones is more appropriate as to what our standard service levels are, hitting those types of metrics that we're not paying for overtime to catch up on various processes or help debug the system or test that system. All of those are metrics that we're going to work on to make sure that we've stabilized the system. The other piece that is being worked on is we have a large file integration with the University of Washington on the PEP side. It is the main additional current IT infrastructure piece. They use the Workday platform, and we've had a file integration since 2017. And making sure that that is flowing into Benefits 24/7, because that's really the first data migration on that side of the population, into Benefits 24/7, into Pay One. Right now, we have that integration maintained with Pay One. We are having such challenges with some of the sync issues related to their specific integration that we migrated them back to Pay One to reduce the bugs that needed to be solved in that instance. But we do need to get it right shipped and moving in the right direction. That's kind of priority number 2 in 2025. And then all of that is leading up towards transitioning that 834 file production that goes to the carriers and getting that as a function of Benefits 24/7. Therefore, there would not be a syncing of data or a difference in data that the carrier gets and what members and benefits administrators see in the front end system. Even if all of that is achieved, and those are kind of the 834 file production may or may not happen in the 2025 range, but the planning and infrastructure and working towards that would be, we're not going to distract ourselves from the stabilization efforts. We also have made a pivot in how we're communicating issues related to Benefits 24/7. And I want to thank Marianne for that leadership. She's been here for a week. And here we are, we're making sure that we are pivoting, and we began a more robust communication campaign with benefits administrators last Friday, explaining that we were making this pivot to talk about what bugs exist. We have a very first version on our primary website that supports benefits administrators for them to be able to track issues. We have a lot more content that we need to go up there, but we've made a commitment to provide weekly progress updates on known bugs and an easier system for people to track what is known, not known, and be able to know if the issue that they're working on is something that they can flag in a ticket to us. They can say bug 1234. This is related to bug 1234 that you've already posted about, but help us kind of triage and be able to connect and streamline some of those pieces. So we've really worked in the midst of kind of overhauling how we're communicating with benefits administrators, about the issues that are in 24/7 pay one and the resulting file. So I just wanted to highlight a little bit about that. And while Mary is here, thank you for helping provide direction on the pivot that we're making on the communications point about this. It really is kind of an all hands on deck piece because now that we've gone through open enrollment, we're seeing, like Clinton said, that the real test of benefits 24/7 was always going to be how open enrollment went. There are significant bugs that we're working related to open enrollment. They are manifesting every day and have been this month. So we're working on that. So just wanted to provide that additional context.
Thank you, Dave. Do we have additional questions or comments for Clinton? Oh, Laura. I see. I'm watching for hands up there. Just gotta jump in. We're the hybrid environment. We're still working.
I don't really have a quick, just wanted to state for the record, as a benefits administrator, the frustrations, just wanted to be the one here to echo what the frustrations that we've had. It is a struggle hearing from our members, the frustrations they have. We're kind of taking that brunt of that, their frustrations. And it's a rare day if I can have a member actually complete the special open enrollment process correctly or actually complete it all the way through. Usually they get stopped and it's just sitting in draft form. So those still take a lot of work. And if they actually work, I have several tickets in, I think right now, of special open enrollments that just, we can't even on our end get them to complete. Also, as someone who meticulously reconciles the billing file that we receive, there's just numerous errors and they require a ticket to be put in and they can be upwards of 5 to 6 months right now for tickets to be resolved, just because usually they're not simple things that outreach and training can. They have to be kicked to IT. And I know, Dave, you had mentioned you're doing some merging between allowing some additional access. That was that communication that came out on Friday. But just really wanted to echo the frustrations. So we appreciate that the roadmap here and that some stabilization work is going to be done. There were some things that we had access to when we were in Set My Account. I know there was some frustrations with the spousal attestation process during OE. Benefits administrators really were not able to help to combat employees with who was still outstanding on doing that process. So that was.
Yeah, and I'm glad you brought up, Laura, the piece about access in Pay One. So one of the things Clinton mentioned early on that is kind of directly related to this, the way we were trying to monitor the syncing issues between Pay One and Benefits 24/7 to make sure that there was a better log to be able to assess what the accounts were that were having that issue, to be able to kind of look into root causes of things. We had limited access in making changes in Pay One by the staff within my division that manage accounts. We actually have lifted that and created a reverse process to still be able to track those, but have outreach and training and other staff within the IRB division be able to make changes directly in Pay One. And that has allowed us to resolve a couple of hundred of issues that were individual tickets that were pending just in the last 2 years. So that has definitely freed up some of the ability to kind of push things through and get the member where they need to be and the member's data where it needs to be, while still allowing us to track it in a different way. So that I'm glad you reminded me to mention that, because when Clinton said that earlier, I wanted to bring that up. And then I did want to give another example. It builds off of the points you were making on spousal surcharge. So one thing that we thought would be helpful to members, but it turns out not as intuitive or helpful to members, was to auto-populate the answers so that they could then hit submit and didn't have to know what they did. But most people didn't realize they had to hit the word submit. And so then they didn't submit anything, which then would default them into paying surcharge. So we're not going to autofill that information in the future because people don't necessarily expect it to be. And it's the wrong volunteer.
I think we got a good volunteer for a focus group.
Yes. We have a couple.
Those, I'm like, no.
Back.
Yeah, so that was a user interface experience, like, oh, this will help people streamline that. Ended up having the reverse effect. So that was a very large issue, and we found a way to kind of address that for the short term. As long as an individual had gone into the system, and if we could tell that they went up to a certain point, then we're just honoring last year's designation on the spousal search rather than defaulting into it. If they never engaged the system, but we had sent them letters saying you need to do something, and they didn't engage, well, then they would be defaulted by being a non-responder. But we went through the data to be able to parse out who reasonably we think probably skipped the submit button. But that's just one example among many aspects, but it just illustrates kind of the extent and variety of topics that we have to work through.
And I think it's just highlighting the difficulty of taking old antiquated systems on mainframes, having to interact with modern systems. Which one is the system of record? How is information getting exchanged and populated? It's very tough, and I know the team's working very hard to correct those issues.
We literally have our feet in 50 years apart from each other from an IT perspective. Almost 50, like 47. Yeah. So like at that point, round up.
Yeah. Other questions or comments from the board? All right. Clinton, thank you. Appreciate it. All right, next up, we got a legislative update and governor's budget update from Kate Walker, Policy Rules and Compliance Section Manager in ERB, and Tanya Duell, their Finance Manager in FSD. They're going to come together to bring a legislative update as well as an overview of Inslee's proposed budget and the materials behind tab number 6. And I think this will be supplementing what we got from Robin, sort of at the high level.
I don't care. You.
I got that. Thank you.
Well, why don't we see whose slide comes up first?
It is.
Oh, well, then, my guess is Kate coming first.
Okay, well, good afternoon, Chair, members of the board, Kate Walker.
Hold your microphone, sir.
Oh.
Means good.
All right. Oh, thanks. Good afternoon, Chair, members of the board. Kate Walker here for another round of legislative updates for the 2025 legislative session. Session started last Monday. We're on day 11 of 105 days, so we're going to be running through April 27th. Unlike last year, where I think I only had one actual update that was live during session last year, and then by the time the session was over, that's when we had our next meeting. So I think I'll have a couple of interactions here. So I'll start laying some of the information about what we're seeing so far, as well as providing just a little bit of background on a couple of legislative reports that we submitted at the end of last year that were reports that were requested of us by the legislature in the budget last year. So next slide.
Hey, correct me if I'm wrong, but you come back periodically during board season as we get deeper in and talk about the pyramid and which bills have made it and moved on to the next level, all that good stuff.
You got my next slide will show the funnel, as Dave likes to call it. We'll see as things get whittled down. So we'll talk about a lot of bills here. I'll go over them, but we won't expect to see them, all of them, make it across the finish line. We're gonna, me and my team, keep a good close eye on all of them and see what's happening, where they travel through the process of how a bill becomes law. And so that my talking points become shorter and shorter as we make it through session. So this is just a quick reminder of how we do bills here at Healthcare Authority. We have bills that come in through our legislative affairs group. They look at the roll call every day of what bills have been introduced during the previous day or during that day as it is right now. And they'll assign it to divisions. They'll think, okay, this bill looks like it's going to impact some of the Medicaid group. It's going to have maybe some legal consequences, maybe going to impact our commercial insurance area. And they'll assign it to the divisions to do some analysis on it. We have a nice form that we have to do bill analyses on it, include a lot of different questions, summarizing the bill, looking at the potential, if there's fiscal impacts to the bill. One that we've recently added, which I think is notable, is that we have a section directly focused on the equity issues that bill may impose, which I think is important for us to be looking at the equity issues in legislation, being able to share that information up to our leadership. And then once that bill analysis has been completed, it goes through a little bit of a rigorous process of review, multiple eyes review each of those bill analyses before it gets input to our tracking system called LobbyGov, and it goes up to agency leadership, and we can discuss, then decide if there needs to be further action taken on that legislation, if we need to go testify at any hearings, have any communications with ledge staff about potential changes or issues that particular legislation has. We divide it up. We divide bills as this kind of quadrant shows you here. We have high priority bills and low priority bills. That just gives us kind of a designation because a lot of bills that will come through that we'll review really don't impact us much at all. But we want to keep apprised of them because it's maybe adjacent to the work we do, or it's something that we just want to make sure we're keeping an eye on in case it does change. And bills might change a little bit, may pull us in a little bit more. But then if we have high priority bills, those are the bills that are going to have certain criteria that we have that's fairly loose, but it's things that are going to impact our program. Things are going to impact our rules or our policies that we need to change. Things are going to have a fiscal impact that if that bill were to pass, we would need to have some funding provided for it for either FTEs or report or contractors or enhanced benefits, that sort of thing. Or if it has any other sort of administrative change it would cause us to have. We need to change up some of our programs or change up some of the way that we conduct our businesses or do the work we do in our division or our agency. Then the other split you see there is whether it's our division lead or we're the support. So if that piece of legislation is far more in our bailiwick area in commercial benefits and our PEB and SEB programs, then we'll often be the lead division on that. If it's a bill that is more of a clinical bill, it's looking at changing up some of the way the benefits are or that are covered under insurances and Medicaid. It might be under our clinical quality and care transformation division, and we'll be a support division providing our input on the basis of what that impact would be on our side of the house. So this is a little outdated because as we have to get materials out the door for the board meetings, this was current as of last week, but as of right now, we've had 64 pieces of legislation that have come in that we've been reviewing and done analysis on and looking at. So I will be ad-libbing a lot of things on top of my slide just to inform you of different bills that we're also tracking that have come out in just the last week. Next slide, please. So here's the funnel, as Lou was kind of mentioning a little bit, and I don't have this updated because at the time I put this out, there wasn't any bills that had actually passed anything yet. But this is that wonderful kind of diagram of how a bill becomes a bill. Remember your schoolhouse rock. There's some great lines we could share from it, but this is maybe a different way of reviewing it and actually going into the details of how bills pass, become laws in Washington state. So it starts being introduced, a piece of legislation, and then it goes, it's oftentimes referred to a policy committee. We're often having our piece of legislation at the healthcare committees, at the healthcare policy committees to be reviewed. Sometimes we'll see some in education if that's the SEB program. Other chambers as well on the policy side. And it needs to be heard at committee and then have an executive action taken on it before the 21st of February. That's the column on the left there. Those are the deadlines at which pieces of legislation have to make it out of that committee or out of that process in order to continue to be alive still. Otherwise, we refer to the bill as dead. It's just, maybe we chum it with different language for it, but that's the, a bill is dead if it hasn't made it past that committee cutoff by that date. So as of right now, there's actually one bill that's already made it through, and it's to the original chamber. And I'll talk about that one in a minute. So it's already made it out of the policy committee. It didn't have a fiscal impact, so it's now sitting on the floor for full vote by the I think it's by the House bill. And I'll update this as we go through, and that way you kind of see the priority of what bills we're seeing. I'll only be referring to high priority bills in this analysis because if they're low priority, we're just not tracking it quite as closely. But when you see this get filled out, the next meeting, we'll see the cascading number of bills that have made it different parts, and I'll speak more about those bills during that meeting. So next slide, please. So I want to take a step back for a moment and talk about a couple of reports that we published recently. The first report we had that was, again, both of these reports were budget proviso requirements of the Healthcare Authority stemming from last year's session. So a budget proviso, sometimes there's legislation that gets passed that says, hey, this is some policy stuff and we want to have an agency do a report on top of the policy laws that we're passing. Sometimes they'll just put a report into the budget and they'll have it listed as a proviso, and that's when we'll get directed to do a report. Last year we had two such budget provisos requiring reports of us. The first that we'll speak about just briefly is a report that asks us to assess the costs of implementing the use of medication for treatment of obesity in the UMP plan. So the report is titled, and I put a link here. We'll be able to provide you a link if you need it otherwise, for our anti-obesity medications in the Uniform Medical Plan. They asked for some recommendations on how that might be implemented. And I think that two key takeaways from that report, first was that there was a recommendation that if the legislature wanted to fund and have have anti-obesity medications like semaglutides or Ozempic or the GLP-1s. There's a bunch of different names. You probably hear about them a lot on social media or People Magazine or other things these days. About the prior authorization for access to those types of medications for the treatment of obesity. Now, currently in UMP, there is access to those medications, but not for treating the condition of obesity. It's only for treating like diabetes, and I think recently there's been allowance for it to be used for the treatment of sleep apnea, but cannot be prescribed currently under UMP or any of our fully insureds for the treatment of obesity. So in order to help try and ensure that we are being good stewards of state dollars, there's the recommendation that we would utilize a prior authorization protocol, a cadence to make sure that there's medical necessity for the prescription and use by members of those medications, and that there's a continued kind of checking in and making sure that it's being well tolerated and it's effective treatment for an individual. Second big point was the line item there on the amount of cost it would have for the PEB and SEB programs. And this is just for the UMP side of things. So to have anti-obesity medications with the recommended prior authorization, the estimated cost from our actuaries would be between $129 and $260 million per year. That'd be for the UMP program for both the PEB and SEB programs. So a pretty substantial cost for that to be included in. So that report was submitted and published last month. And we have seen there is some legislation that has been introduced that's not directly tied to this legislation, but it is for the requiring fully insured carriers to cover anti-obesity medication, and I'll talk about that in a second. The second report.
Real quick.
Yes.
A couple of things I just wanted to highlight. A reminder that the current state budget language that is enforced right now does squarely limit the question on whether anti-obesity drugs will be covered in the Uniform Medical Plan and the PEB and SEB programs with the legislature. So we've talked with the board over the years about the ability to kind of swap benefits, if you will, as long as it's kind of a net neutral thing. We can bring you something to talk about making refinements that don't increase. This topic was squarely carved out in budgetary language to say the legislature will make the decision on whether anti-obesity drugs are covered. And then this report was asked of the agency of if the legislature says cover, what would be some insights on how to make that coverage. So this report wasn't about whether to cover, it was how to cover if the legislature makes that decision. But I did want to remind everyone that as members advocate to you, to the board about making this coverage determination, this isn't a specific benefit authority piece that has been retained as a decision by the legislature. So we can move on from AOMs.
Thanks. All right, the second report that might be of interest to the board here. We were asked to provide a report about the consolidation of PEB and SEB programs. Specifically, the legislature asked us to look at three components of consolidation of the program. One, they want us to look at the consolidation of the board from the existing two-board structure of the PEB board and the SEB board into a unified single board. Second, they wanted us to combine the non-Medicare risk pools. Now, just as a reminder on what that means, the SEB program has one risk pool in which all the subscribers and all the people in the SEB program are all pooled together for the purpose of rate setting everything on the SEB program. In PEB, there's two risk pools, and that's the differentiation between the two is Medicare, if you're a Medicare, on Medicare or not. And so we usually refer to it as the Medicare risk pool and the non-Medicare risk pool. The non-Medicare risk pool being every retiree who's not Medicare eligible, and every other person in the PEB program. So they asked us to combine those two non-Medicare risk pools, the SEB risk pool and the PEB non-Medicare risk pool, into a single risk pool and leave the Medicare risk pool as is. And then third, they wanted there to be a consolidated benefits portfolio for the now consolidated program. They didn't ask us for recommendations. They just asked us to kind of provide a report that says how this would be done, how it would look, what are some of the ways it would administratively function, some recommendations on what the board structure could look like, just putting some things out there, or some suggestions. That was not a recommendation. I just said we didn't do recommendations, but we did suggestions on what a board could look like. I know we had listed talking with the board last year a little bit about that as we were contemplating. I know we did stakeholdering with a lot of folks, board members included, about what ideas about a board construction would look like. We provided several options for what a board could possibly look like. But the key component of it that was called out in that proviso was that they want to ensure that all of the current eligibility frameworks that exist today in both the PEB and SEB programs would remain unchanged. So they want to make sure that in a consolidated program that we would be able to affect that that transition of all the eligibility rules and policies and laws into a consolidated program without causing any unintended or any change in eligibility, so that every person who's currently eligible for benefits in either the PEB or SEB program would continue to have that same eligibility in the consolidated program. Lastly, and what I want to call here is that the last thing they asked us to do, and if you look in the report, you won't necessarily see it right out there, but it's an appendix to a link. There's a link in that appendix to all of the statutory changes that would be required to affect these changes. That was the budget proviso for this report, was to have us draft the statutory changes that would need to be made in order to affect the changes and consolidate the program. So that was done. It's about 90 pages worth of statutory changes. And rather than have a 40-page report and 90 pages of an appendix of statutory work, which is wonderful to read through, I must say, we provided a link. So if you were to click on that link, you can see the statutory changes that we put together to affect all of those changes that they asked for in that proviso. And I mentioned that, kind of call that out, because there is now legislation that has been dropped that utilizes the statutory changes that we put forward as a basis for them to then write a piece of legislation to consolidate the program. So I'll speak to you again in a second. I see Pam's finger on the mic.
We want to do questions throughout this, or want me to wait till the end? Okay, and I have not read the 90 pages. I'll fully admit that. With consolidating, is the purpose to be more efficient? Is it the purpose to save money? What's the intent of consolidating the two boards?
I wish, I mean, it'd be nice to know from the legislature what they're completely thinking. It wasn't at our request to do any of this. It was that proviso that instructed us, write a report, tell us how it could be done, so that if we decide that this is what we want to do for whatever reason, that we would do it. And being the experts and the kind of subject matter folks and the people who know this, we put it together and say, if that's what you want for whatever reason, here's what it is. I don't know exactly what their rationale is for that. I don't want to begin to opine on it. There's, like you mentioned, there might be some of those aspects administrative. Certainly having a consolidated board, one board instead of two, it's a little more administratively simple. I mean, I think that's just kind of apparent on its face. The cost saving aspect, we've already, I'll take a step back. Consolidation has been a topic that we've discussed for a lot of years, since the 80s, when the first report on consolidation was done about consolidating the K-12 purchasing. And that was from 87. And then there was work that was done. They attempted to consolidate all the purchasing for K-12 in 92, then that was repealed in 93, which is why all the retirees from K-12 still remained in the PEB program. And then report. We had a report in 2014, which is then what was the last report before consolidation of the purchasing for K-12 benefits was done. We created SEB. We then had another report that was done about potential cost savings of consolidating the program. So I mean, there's a history of maybe 15 or so reports about consolidation that have looked at different aspects. The report that was done a couple of years ago did look at some of the financial implications of consolidating, and I don't have on the top of my head a whole lot of information on it, but there's differences, and at the time SEB program was very new, so there wasn't a lot of information that we could definitively say one way or the other what would happen and what one program might have a benefit over the other, things of that nature. So there has been a conversation about that in the past, but that's not what this report focused on at all. So that's a long way of saying don't know for sure, and we're not leading the charge one way or the other. We're trying to make sure if that's what they want to do, we have it done as effectively and completely as possible. If that's the policy decision they choose to go through.
Can I ask a follow-up?
Of course. We're not holding you to one question today.
Oh, thank you. Will consolidation save money?
Anya.
I came on green really quick. I think when we talk about consolidating the risk pools, right, we are still going to be covering the same number of lives when we push them together. So when we look at consolidating the risk pools from that perspective, there's really a very minor, less than a fraction of a percentage change to the whole state budget. We spend over $5 billion a year between the new programs. So we're talking very minor percentage change when we combine the programs. Where we wind up seeing differences is when we look at different scenarios of what we think will happen. We don't know what plans would be offered. We don't know what the benefits of those plans would be. We don't know how members would choose to enroll.
And being that the state's costs are benchmarked off of a UMP plan, so in SEB it's a UMP Achieve 2, and in PEB it's UMP Classic, we have to really look at the different risks of those populations that are enrolled in each of those benchmark plans, because those are what drives the cost to the state. And we have to look at what we think will happen in those enrollment situations. So everyone loves a good analogy, especially a fruit analogy, I think. So when you look at, we think of it as like the concentrate, right? So if you have like a apple cranberry juice, right? Which concentrate is going to be more powerful in that juice when we mix them together? So we have the PEB program, which does have a higher risk score than the SEB program. But depending on which people choose which plans and drive that state cost for the benchmark plan, we get various outcomes. So the total cost should be the same number of lives, but there will be scenarios where maybe SEB will pick up more costs, PEB would pick up less, or vice versa, just depending on how that mixture would actually come out once we have an active open enrollment. That is just the risk pool part. On top of that, there's going to be some administrative efficiencies that are kind of hard to cost out at this point, but there will be some minor printing savings, actuarial savings, maybe some small upfront IT investments to get the systems working together. So there are some areas of administrative efficiencies, but really the big cost comes from that risk. And when you look at it together, it's kind of neutral.
And just to add on, when we say things like neutral, that's in the context of $5 billion. If we see an administrative reduction of 1 or 2%, and that's $3 to $5 million, that's the totality of multiple small agency budgets for a biennium. So that's not small in the context of when you're looking at it from that perspective. But when we talk about the cost of these programs, the shift is relatively small or neutral.
And maybe fair to say it's small in the context of the deficit that the state's currently facing.
Yes, it's also, yes, it is.
You get some long-winded answers from this.
I'm like,
But that one wasn't, we don't know.
You want to take another shot?
I'm concerned that, when we say I don't know, it depends on who enrolls and who does this. And then what my main concern is premiums going up, members distrust of SEB, PEB, whatever letters you want to throw together.
Word is the bill.
That's bad.
We'll go with that.
Ultimately, our members need to trust us. Ultimately, we need to keep premiums down. I'm not seeing, I'm concerned. There's too many moving factors. And I would like it to say, if we do this, this is the cost. And when there's too many moving parts, it makes me very nervous.
It makes me nervous to also have to put a dollar amount to it when there's all those moving pieces.
Right.
So I understand, I totally know.
It's very hard to determine too in the future. You may have a negligible impact in the beginning, but as time goes by with the increased, and I'm going to say this with a caveat, with sort of the increased purchasing power, because now you're sort of having one set of plans for both programs. There may be advantages that come down the future, but then you're using like may, possible. You're using all these words to imply we don't know. And that is the truth. We don't know. There would be administrative simplification. That one's easy to identify. Yes, that would be true. But to your point about premiums, would premiums change? Of course they would. They would do what they do when you're taking two different pools, you're putting them together and you're recalculating the premiums. And if they harmonize the back end employer contribution component, and then the leftover is sort of left to the member, there will be changes. And as with all, when you have one bucket of money and you're moving things around, the old adage of winners and losers, that there will be some people who will benefit from it. There will be people who experience maybe some increases on it. And that's just sort of the nature of set amount of money, set amount of people providing services to them.
To take Tanya's analogy further, it would seem like cran apple and apple cran juice would be the same, but they really do taste completely differently for anybody who's had them. And so it really can actually produce very different results.
Now I'm getting proud that you
totally
reused
lost
my analogy.
analogy. I'm like, I don't know. What we're saying is one flavor might dominate another flavor. We're not sure.
Yeah, we're just saying that the PEB population does have a higher risk pool for score, and depending on how much of that concentrate ends up in the final mixture, has profound swings. It could either have minimal swings or bigger swings. It really just depends. And I think another factor here to think about is in the PEP program, there are fewer plans and fewer carriers. And so it is not necessarily assumed that the where those people would switch to if the portfolio ultimately looked more like SEB and had an additional carrier in the mix, or another procurement occurred and there was even more carriers than exist today. That shuffling of the deck is, the various versions of Grand Apple Grant that you can get. I like that. I'm maybe using that for a while.
It was just for you.
Okay.
Mezcal.
Any other questions at this point? We do. Donna.
She asked a lot of the same questions I had planned to ask. The only other one was I did read the report, not all the statutory stuff. The tiers were my biggest concern because it really looked like about 80% of our members would see an increase if the tiers changed versus 20% that would see a improvement. So that was a big concern. If a bill was proposed, there would be a cost analysis of some sort done, I assume.
I can answer both of those. So, Donna, can you hear us, Donna?
You still with us? Oh, you still with us, Donna? You're muted.
You can shake your head.
Yeah. Once you unmute, then you have to get permission to unmute again. So, yes, I can still hear you.
Okay, so I think your first question is around the tier factors. And I just want to caveat all of this by saying we had to make some assumption for modeling purposes. That does not mean that is what is going to happen in the ultimate outcome. We believe that the boards or the new combined board would have the authority to set those tier factors, where we would bring back all the different options. We would show all the different iterations of the various tier slices. The current legislation in its current form states that it cannot be more than 3 times the single subscriber, and that's what exists in the SEB program today. The PEP program does not have that same language, whereas in PEP, though, the full family is 2.75. So when we looked at the actual breakdown and the cost for those tiers, the recommendation in the report, it's really not a recommendation, it's the modeling we use to be able to produce some numbers, was that 2.75 that aligned with PEP. So I understand, but I just think we need to say, I think at the very end, the board would have the final decision on what the outcome was. What we chose was for purposes of modeling because we had to pick one way or the other. And then your second question was the fiscal note. Yes, so we the bill is dropped, and we did do a fiscal note on it. So the fiscal note will be public. It got released late last night and needs to go through approval of the Office of Financial Management before it's public on the website, on the LEDGE website. If you need a link, I can send you the link of where it gets published. But it does largely align with our LEDGE report. We just released that in December. We didn't have enough information or time to do any different analyses. So our fiscal note will largely just match what was in the legislative report with the addition of some administrative caveats.
And does that fiscal note only take into account how much it's going to cost the state? And does it go into anything about how much it might cost the subscribers?
So the legislative report and the fiscal note both have tables for both the employer costs and the employee costs.
Thank you.
You're welcome.
Other questions? Back to you, Kate.
I'm going to skip ahead just real quickly to tie up the legislation. Thank you.
You're good.
There we go. Great. All right, I'm going to just skip ahead just real quickly on the PEP-SEB consolidation bill. As Tanya mentioned, there has been legislation that has dropped. Senate Bill 5086 and House Bill 1330 is the PEP-SEB consolidation bill. So they did take the statutory language that we had drafted and they put that into a bill. They went with the Washington Employees and Retirees Board, or the WERB board. So take that acronym as you will. I think our communications team will have some fun trying to come up with how to market that a little bit. They also chose for the board construction. So when we did our report, we put in a few options for them to consider on the number of board members and what those board members might represent. They went with a 13 board size with 6 members that are representing kind of the health policy and cost containment side of the board, with a little bit more special caveats in there, that there'd be a member who has expertise in health equity, a member representing the state HR, Office of State HR, a member representing the Department of Retirement Systems, because given the impact that the carryover of things that we have in our PEB program and really with SEB as well, with our retirees and DRS, it seemed to make sense to have someone from DRS be on that board. So unlike what has happened previously with the PEB and SEB boards, where the cost containment policy board members were just listed as that, cost containment without any other sort of qualifiers, we wanted to be a little more specific and ensure that there's maybe some other opportunities for expertise to be represented on the board in those different topical areas. There's 6 other members that would be representing the employee side or the member side of things, 2 representing school employees, 2 representing state employees, and 2 representing retirees, with 1 representing school retirees and 1 representing public employee retirees. But then the chair of that board would be the director of the healthcare authority or their designate. Other than that, there really wasn't too much differentiation between the legislation that's been proposed and what we had put into our report. Because I'd like to think my team did a really great job at drafting things. Now we do have some potential amendments to it, just other things when you're looking at such a large piece of legislation. There's a lot of nuances and other sort of links and cross links to different parts of statute that we needed to clean up. So we do have a couple of things that we're proposing if there's going to be an amendment on that legislation that we'll see go forward. But as it is right now, there is the fiscal note that was just approved internally last night. So we'll see that published shortly. And last I checked as today, I didn't see it scheduled for any hearings currently, but it has, I'm thinking that's correct, maybe James.
I'm just double checking.
Yeah.
Actually, it was scheduled for a hearing next Thursday.
Okay, so it's good, and it's both of those versions are in they skipped the policy committees, and they've both gone to appropriations and ways and means. So that means it has until February 28th at this point to make it out. So it's a little bit longer, just a week longer than the first cutoff. But
Yeah, as a reminder, often bills relating to the PEB and SEB program don't go to a policy committee. It's seen as fiscal policy because it's related to the compensation side of the legislature's work. And so most bills related to PEB and SEB directly go to the fiscal committee and skip because it gets fiscal policy.
Okay, so I'm going to go back now. I'll move forward in the presentation. We have a couple of pieces of agency request legislation that we want to speak about. First is a piece of legislation coming out of our policy shop at the Healthcare Authority, House Bill 1123, Senate Bill 5083, companion bills related to ensuring access to primary care, behavioral health, and affordable hospital services. This is legislation from our policy shop that's intending to try and, first off, I think, mitigate a bit of the churn that happened in provider contracting and incentivizing provider groups, large provider groups to stay contracted with networks, provide some frameworks to try and encourage that, and incentives to stay contracted with and not have there be the drawn out process that they have a lot of consternation that causes our members when they get letters saying your provider might not be in the network next year. Try to help ease some of those contracting hurdles that exist or barriers that exist. As well as trying to expand some of the access to hospital services and behavioral health services for our networks. So we're tracking that. We'll see what happens there. The other piece of legislation that is coming out of the ERB division is one related to the PEB board authority. It has now been dropped. It's House Bill or Senate Bill 5478. Thank you to Senator Bateman for introducing that. What that is doing is, you'll recall when we formed PEB or SEB in 2020, we became aware that there were ancillary and supplemental benefits that were being offered by districts, and there was some concern about whether there was some competing authority or competition between the benefits offered by school districts and what was going to be offered by the SEB program. So in 2021, we had legislation that was passed that said as long as the SEB board is not offering a benefit that, or that the school district is not offering a benefit that conflicts with the benefits offered by the SEB board, then they can continue to offer it. And then they also granted the SEB board, which you have in statute in current 4105-745. There's a list of about 10 different ancillary supplemental benefits that you can pick up, subject to funding, and choose to have studied about offering to having offered to the SEB program. Those are things like pet insurance or legal assistance insurance or expanded property and casualty insurance. The cancer insurance was one that we heard a lot about, our emergency transportation supplemental insurance. So you have the authority to offer that as a entirely voluntary and employee paid benefit. should you so choose, and there's funding to do so, to do the administrative aspect of it. This legislation that we've introduced this year would extend that same benefit offering authority that the SEB board has currently to the PEB board. So that if they wanted to then choose to take up any study of those benefits, like pet insurance, which is one we surprisingly hear a lot about, and other types of benefits that could also be offered, which would then create a good synchronicity between the two programs of being able to contract and do an RFP to offer those benefits in the future if they so chose to do so. So we're going to keep track of that one. I'll move forward. Next slide, please. Current legislation I talked about, Senate Bill 5086 and its companion bill, which is 1330 in the House. Sorry, I should back. On the current legislation, I try and kind of bucket into sort of topical areas, administrative aspects of changes to the programs, providers, pharmacy, insurance coverage, new insurance requirements, that sort of thing. So under the administrative grouping, I have that PEB and SEB consolidation bill that we'll continue to be tracking very, very closely, and then we have House Bill 1069, Senate Bill 5044, which would allow for retirees to be able to collectively bargain for inclusion in certain supplemental retiree benefits that be offered through the PEB program. Don't know too much more what they're considering there, but it's a little bit vague as far as the scope of what they would intend or hope to be able to bargain for at some point. And I think it kind of does go hand in glove a bit with the PEB board expanded benefits offering authority that they may be wanting to seek to have some additional benefit types be made available to retirees that currently aren't available to them or to anyone in the PEB or SEB programs. Additionally, there is a bill that's coming out of DRS that we're tracking that's regarding the last month of death regarding their pension. You may recall last year there was legislation similarly situated to this where we had some language in there that also impacted our program, which allowed for when a retiree, someone who's enrolled in a DRS plan, passes away, that the premiums that they have for the month of death is waived from us. There had been a bit of a problem what we had historically, that when a member passed away and they have auto deduction from their retiree pension for their benefits, that in the month of death, DRS claws back that last payment that's made to them, and they would be left with a balance owing on their account, which in the month of death was not a great situation. So it caused a lot of administrative struggles for us, a lot of headaches for the family members of the deceased retiree. And so last year, when that legislation was introduced, they did end up passing the part of the legislation that allowed us to waive the premiums for the month of death, but they did not pass the part that would allow the DRS to make a full payment to the retiree and their estate and their family members on the time of death. So DRS has now put forward that legislation again to have that last month of death pension be made in full to the retirees, which then would probably have an effect of us being able to no longer have to waive the premium for the last month of death, which would be a cost plus to us. We're going to be talking with the legislature about making sure that gets taken into consideration if they're going to move that bill forward, so we can have that cost savings back to us.
Hey, before you move on from administrative, I anticipate a question that Donna and Pam would appreciate knowing. So I looked up the bill real quick to make sure I was remembering this right. The board that's envisioned under Senate Bill 5086 and 1330 specifically designates that for school employees, one would be representing classified and one would be representing certificated. And then also for the state employee side, it's one for state agencies essentially and one for higher education. And then of the 6 administrative health policy experts, one of them is demarcated for WASBO continuing on. So just wanted to highlight a little bit more about that nuts and bolts. And then as I was thinking about our apple cran juice, I wanted to go back and highlight a little bit about the cranberry juice, which is the PEB non-Medicare risk. We talk about how that concentrate matters because the risk scores are different. Just want to highlight that one of the differences is all non-Medicare retirees, regardless of their former home employer, aka K-12 or state agencies, are in the PEB non-Medicare risk pool. So inherently, there is an older population that is implicitly subsidized in that pool and is a contributing factor to why the risk scores are different. So that's one of the underlying reasons why cran apple juice exists. So just wanted to do that before we went on to provider bills. Oh, but Karen, I prompted a question.
This is a small technical question. You were talking about collective bargaining for retirement benefits, and you said bargaining with retirees or bargaining for retirees. I didn't know how you bargain with retirees.
I'm not entirely sure on that. I'd be happy to look it up more specifically and find out the kind of administrative aspect of how they plan to administer that. I'm not entirely sure though. At the top of my head.
Find the group and it's a novel. Let's have unions and other groups.
Thank you for the question. Lastly, on the administrative side, I'd like to make aware when there's any potential new populations that would be added to any of the PEB or SEB programs. There has been legislation introduced, HB 1354, which would allow for employees that are here for the legislative session, that work for the legislature during session, to have be available to be eligible for PEB benefits. So that was recently dropped. So we're going to be watching that and see if there's a new population that will be added to the PEB program after the session ends. Let's see, moving on. So we have then providers. I'm actually I think this is an interesting piece of legislation, HB 1124, 5112, although I probably shouldn't say that, but I think it's interesting. It's allowing psychologists to have prescribing authority. So it would allow for a new certification from DOH to allow for psychologists who don't go to medical school, have formal medical training, to be able to then prescribe medications for the treatment of behavioral health conditions and mental health conditions. So we're keeping track on that. There's also HB 1114. This is another bill related to compacts that are created from our state with other states. And we've seen several of these in the last little while. Some related to mental health services, some related to radiology services, where there's compacts between Washington and other states that allow us to recognize the licensure of provider types from other states and allow them to practice in our state and vice versa. These are pieces of legislation that are meant to help address provider shortfalls and make sure that we're doing everything we can to try and increase the availability of providers, especially for individuals and systems that are on the borders with other states. There is House Bill 1535. Sorry, I'm trying to read my crappy handwriting. Regarding dental insurance practices, with certain protections that they have that are intended to mirror the protections that exist in medical insurances that I guess don't currently exist for the dental arena, as well as requiring a similar 85% spent on services for dental carriers, similar to what exists currently for medical carriers. Let's see, next slide, please. On the health plan coverages, we again see legislation to require coverage for biomarker testing. We have a slate of legislation related to reproductive rights, women's health care. We have HB 1090 related to contraceptive coverage. This is actually a pretty small bill. It's already passed out of the policy shop and is onto the floor. There was legislation passed a while ago that said that all refills for contraceptive coverage could be made out of have a 12-month supply for contraceptive coverage. This is now allowing that the initial prescription of contraceptive coverage can be made for 12 months. So it's a little technical, but I think there was maybe some concern that it wasn't clear, so they just clarified that in statute. There's the House Bill 1129, Senate Bill 5121, that has a significant impact, would have a significant impact on our carers and the services provided related to fertility, the diagnosis, the treatment, and preservation for fertility services. We have Senate Bill 5075, which is eliminating the cost sharing for prenatal and postnatal care. Then we have House Bill 1326, Senate Bill 5353 related to diabetes. This is the medication, the GLP-1 semaglutide medication bill. It requires that not only medication, but for surgical interventions to be included as coverage for all fully insured plans in the state for the treatment of both diabetes and obesity. So that is legislation we're tracking because that would have a significant impact on our fully insured carriers having to have them require coverage for obesity medication and for surgical intervention for obesity. There is Senate Bill 5395 that's related to prior authorizations with the intent of improving the prior authorization process and increasing transparency for prior authorizations. Something that we're also watching is the impact it would have on our carriers. There's on the pharmaceutical side, we have House Bill 1186, medication dispensing, allowing hospitals to have expanded authority to provide medications related to the treatment of HIV and its different iterations, to be able to have them be able to prescribe that more readily through the hospital systems. Senate Bill 5019, prepackaged medication distribution, allowing for the for pharmacists to be able to provide extended 12 months supplies of certain medication types that it's currently limited to 90. They'd be able to prescribe up to 12-month supplies if it's in a prepackaged form. There's Senate Bill 5326, which tells the Healthcare Authority to establish a program to provide emergency insulin for individuals who are experiencing a crisis and don't have access to insulin. There's House Bill 1520 that would allow pharmacists to have some prescribing authority for certain types of medications for them to be able to provide directly for things like immunizations, EpiPens, HIV, contraceptive, where your pharmacists, especially pharmacists in rural areas, would have the opportunity to actually prescribe and help with refills for individuals who come in to get medication. Oh, and that's it. Those are my notes. Happy to answer any questions, or I'll turn it over for budgets.
Tanya?
Oh, I think I'm gonna go ahead and go back upstairs. And, thank you. But I just, want to again, thank you all for the work that you do. I really appreciate it. And I know being on a board is not always that easy. And so, again, thank you and the good work that you all do. And these were great presentations. So I'm glad I have had the opportunity to come and join you for a while. So thank you for lunch. And I'm sure I'll see you all again. Thanks.
We're going to transition over to the budget discussion portion of the legislative update. And just for the record, since I've already talked a bit, my name is Tanya Jewell. I'm the Herb Finance Section Manager. And I think Megan might pop up here to chime in on a few things. So great to be back. It feels like we were just doing rates just like a couple months ago, but it's been a half a year. So we're going to walk through Governor Inslee's proposed budget next. And I want to caveat that by saying this is all based on Governor Inslee's budget, which we know is no longer our governor. And so just that little caveat that everything is proposed under that administration. What we've seen from Ferguson is some of what Robin walked through earlier today in the list of budget priorities that she addressed, some of the 6% agency cuts across the board, some of his priorities around funding the collective bargaining agreement, investing in law enforcement, things like that. But there was no formal budget release to walk through with you today. So this will all be based on Governor Inslee's version of the budget that came out in December. So next slide is just a brief timeline of the budget process. So during the summer each year, the agency works on creating what are called decision packages. These are our requests for funding. These are ideas that came from the board, came from the public, internal, from our carriers. They come from all different sources, and then the agency works on a process internally to cost these out, talk through the options, and prioritize them within the agency on what will go out in a formal decision package request. So that is all done in the summer, released late summer, early fall for consideration by OFM in the governor's budget, which comes out in December typically. So that's what we're going to walk through. Next up, though, we will have a House version, a Senate version, a final conference budget, and then the governor can veto certain things within the budget. And as we progress through that process, we'll bring back updates as the board meetings kind of converge with those various budgets that we have. First up, we're going to do a little pit stop on the supplemental budget. The supplemental budget is something that is addressed in all of the budgets, whereas the biennial budget is just addressed in the long session budgets, the odd years. So the supplemental budget really just gets us through from now through the end of the fiscal year, which ends on June 30th. So you can imagine when session ends at the end of April and the dollars are only available to be spent through the end of June, it's a very small list of things that we usually ask for. The first one up is our third-party administrator, TPA, spending authority. This is something you guys hear me bring back every single time because our third-party administrator spending authority is based on enrollment within our self-insured medical plans and our self-insured dental plans. Back in 2024, we all remember the larger increases we saw within some of the Kaiser plans and some of the switching that occurred. That drove larger enrollment in our self-insured plans and the need to go out and ask for additional spending authority for our accounts that pay for our third-party administrators. What you see here is just the amount to get us through the end of the biennium. The second item on this list that was included in Governor Inslee's version of the budget is dollars related to a contract increase for our actuarial support. So the PEP and the SEB program contracts with an external third-party actuarial firm for some of the more complex modeling that needs to be done. Within the PEP program, we have not seen an increase to this budget in at least 10 years. And since the inception of the SEB program, the budget has remained the same. However, the complexity and the volume of work that is, really put on us by, external parties, the legislature, has really increased over the last few years, meaning we needed to do a small minor increase for that budget as well. Okay, we're going to transition over to the biennial budget, which has some more exciting things. First, we'll do a brief update on the collective bargaining agreement. Okay, so HCA supports OFM and statewide HR every other summer in the collective bargaining process. We support on the healthcare table for things like modeling of benefits, modeling of the employer medical contribution, and help do that and assist OFM. Some of the things that came out of that tentative agreement, which are up for consideration and funding by the legislature right now, are maintaining the EMC at 85%. So nothing was changed with the employer medical contribution. It's still going to be benchmarked off of UMP Achieve 2 at 85% of that bid rate. One new and exciting thing that is in there that Kelsey will talk about later is a new employer contribution for a flexible spending arrangement for certain employees who meet certain salary and eligibility criteria. Kelsey's going to do a full presentation on that coming up this afternoon. So lastly, this agreement will become final once it's funded in the final budget. So we'll give you more updates as we have our final budget. So the first two items on the biennial decision packages align with what we just talked through on the supplemental, just larger in volume because they're over 24 months versus the last few months of the biennium. So again, our third-party administrator spending authority increases and our contract increases for our actuarial work are both funded for the biennium under this version of the budget. The third item on this list is really exciting. It was one of our agency's highest ranked decision packages. When we look at both PEB and SEB and Medicaid combined, it ranked really high within the agency's priorities. And that is an FTE package to support the benefits 24/7 member enrollment system that was talked about right around the lunch hour. So in the SEB program, there were 3.5 FTEs funded in this version of the budget. In total, when we look at the PEB and SEB together, there were 9 FTEs funded. When we do joint packages between the PEB and the SEB program for things like this, I just want to point out a lot of times things are more heavily weighted towards the PEB program because of the support for the retirees. There is work, obviously, that is needed in the enrollment system to support our retirees as well, and we don't want to charge that portion of it to the SEB program. So things that combine both the PEB and SEB program and impact retirees, it's sometimes weighted a little bit more on the PEB program, if that makes sense. I'm going to just make one little comment here. We all heard Robin this morning and the budget deficit that is, the state is dealing with and trying to fill. And it might seem a little, odd that we have a pretty large decision package that was funded here. But I think the state is recognizing in this situation how important investing in our enrollment system is. So I just want to point that out really quickly here. On the next slide, we're going to see two small items also that were funded in this budget. The first one is doulas. So we requested funding to provide coverage for doulas in the Uniform Medical Plan. Currently, doulas are not a reimbursable provider type within our Uniform Medical Plan or our fully insured carriers. And these became a valid licensure type a while ago. So we are working through the operational impacts with all of our carriers on getting contracted, getting a network set up, and if we can pull off some of these operational challenges, the budget included the funding to pay for those increased claims for doulas within the Uniform Medical Plan. And then the last one on this is just administrative funding to support our agency request legislation, Senate Bill 5083, that Cage spoke to around some of the hospital pricing and affordability bills. So there is a little bit of administrative work that goes with that agency request legislation.
Tanya, can you remind people about the relationship between the dollars that we talk about here and the general fund?
Yeah, okay. So So one thing to point out is when Robin was speaking about the budget deficit, she had her pie chart up and she was focusing on the general fund portion. The SEB program is not fully general fund funded for purposes of SEB benefits. It's about 80% of our expenditures in the SEB program are general fund, with the other percentage being some local dollars. So when we look at things in terms of general fund impact, we break things down into that percentage. And then the other percentage we want to talk about is in terms of funding rate dollars. We all talk about the funding rate a lot and what's included within the funding rate that the districts pay HCA to cover employee benefits. It takes about $1.7 million to even change that number by $1. So when OFM is looking at funding things, and even the legislature, they're looking at that scale, right? So something like doulas, that's 200,000. It's not going to impact the funding rate. It's not going to drive an expense that they have to push out to increase the funding rate for each of the districts. So I think that's the scale of percentages you're referring to. Okay. So next up are a couple additional items that were in Governor Inslee's budget that were not related to decision packages. And the first one up is about combining the PEB and the SEB sections of the budget. This is not full consolidation that we did a pit stop on a few minutes ago. This is just technical, kind of in the background. Right now, when you would look at the operating budget, you would see two completely separate sections for PEB and SEB. And when we look at things like our chart of accounts on the accounting system, you see two separate sections. All this is doing is combining those into one section for ease of accounting purposes. Where we have maybe 5 administrative accounts on PEB and 5 on SEB, we will now have 10 in one program. So there's going to be no commingling of funds. Everything's still going to be accounted for separately. It's just aligning them all into one program under PERB versus a PEB and a SEB administrative section.
Tanya, people might wonder what an advantage is of that, and I think you've described one before, how when things are put in the system, if you're literally in one screen, you can make sure like that allocation between PEB and SEB is kind of keyed correctly, for lack of a better word. Whereas if you're going between multiple sections of the budget in the state's budget system, there's higher risk of human error in aligning things when there's that.
This recommendation actually came out of the legislative staff a few years ago, because on the background, when they're working in the system for things like our joint FTE package, for example, they have to flip between the two programs every time they make a change. So if they want to fund all of the decision package or half or pick and choose, they have to flip every time between programs. And then there's been instances where the SEB program got funded with the PEB funds or vice versa, because it's just a little messy in the background. So this will help with some of those errors that happen. Okay, the next one up that was in the governor's budget was the authority to increase the employer paid long-term disability from $400 to $450 per month. Right now, a portion of the funding rate, about $2, is attributable to the employer paid long-term disability benefit. And within that $2, the actuaries over at the Standard have determined that that $2 can now go a little further. Instead of just going to $400, we can increase that to $450 within that same $2. And this is exciting that the governor's budget allowed us to increase the budget instead of saying, well, then we want 50 cents and you only pay $150, for example. I'm just making up numbers, but it was great that they allowed us to keep that same investment of $2 while increasing the benefit. Dave, anything that you want to mention on LTD?
Just that it's exciting to be able to make any progress on the LTD benefit. I know $50 is $50. And it would come with a small rate reduction on the employee paid side, because as you increase the employer paid benefit, then the next dollar of insurance that's covered by the employee is, there's a little bit of a relationship there. Went back into the histories because I know the board's aware that the setting of the LTD benefit for SEB perfectly leveraged the existing historic benefit of a $2 investment from the PEB program. The last time the PEB benefit was changed was 2003, so this hasn't had any additions or adjustments in over 20 years, and so it only took 5 years for there to be the first adjustment in the SEB program proposed and included in the governor's budget. So I always wanted to be more, but given the fiscal dynamic of the state, I'm glad the $2 investment was continued to be supported rather than literally nickel and dime to help with the larger state budget deficit challenges.
On the next slide, we're gonna address some of the budget deficit challenges and those impacts on our SEB program. The first one up ties to the last item around long-term disability. And because that $2 has been able to go a little further, we have built up some of our long-term disability employer reserves. This was one of the items that was up on Robin's slide that Dave said we would talk about later. So in our employer paid, and I'm emphasizing employer because employer and employee reserves are kept completely separate. They are not commingled in any way. In our employer funded claims fluctuation reserves, our CFR reserves, we have dollars that are above and beyond what is required to keep in those reserves. And we are able to withdraw those and deposit those into the general fund to help with the budget deficit. And currently for the SEB program, those are around $2.6 million. What you might have seen on Robin's slide was a larger amount for the PEP program, and that is just due to the longevity of the PEP program versus the SEB program and how long the PEP program has been building up their reserves. And the second item up is regarding the closure of the UMP Plus plans. So I'll do a little bit of history on our UMP Plus plans. We have two UMP Plus plans with two different networks. Essentially, they're the same benefit design, same premium, but there's just two networks, one through Puget Sound High Value and one through UW. These plans initially started in 2016 and were the agency's real first push into value-based purchasing arrangements. In fact, at the time, they were super innovative. We had other large employers in Washington who reached out to us to kind of piggyback on our modeling. And we've learned so much from these plans and the value-based purchasing arrangement. Pretty early on, we did a major course correction to that contract in 2017 for some of the future years and how the terms of that contract were shared between the state and the networks. And currently, those arrangements are really, favoring the networks a little bit more than the state at this moment. What we really need is another course correction like we had in 2017. And we tried that. The agency went out for a reprocurement of these networks about a year or so ago, and it was unsuccessful. The current contracts are set to end at the end of calendar year 26. And what you see here is Governor Inslee's budget actually closing the plans a year early at the end of this current calendar year. And I think what this is saying is we're recognizing the value of these contracts at the time of trying to balance a budget deficit and recognizing that they could close these plans a year early and use those funds to help with the budget deficit. So our members, as this states now, again, there's a lot that could change between the House and the Senate budget, but our options would be that members would have to select a new UMP plan or any plan. However, if they were to select a new UMP plan, they would be able to maintain their provider relationships. The UMP Plus networks are a very small subset of the overall statewide UMP network. So as long as their providers maintain a relationship with regions and contracted in the UMP network, members would be able to maintain those provider relationships. We do acknowledge that there are some benefit design changes or that would happen, right? This plan is pretty rich with the lower deductible, the pre-primary care cost savings. Cost sharing savings, but what we're noticing is an increased trend in the premium in these plans. Specifically in the PEP program, the UMP Plus plans now cost more than the benchmark UMP Classic plan. So they cost more than the SEB equivalent UMP Achieve 2 plan. And we expect that trend is going to continue with the way these plans are currently structured. Megan, Dave, anything?
I'll just answer the question that I positive somebody who asks, how many members are currently in those plans? 14,442 between the UW and the Puget Sound High Value Network, slightly slanted towards High Value Network over UW.
In SEB.
In SEB. That's the SEB
total
number.
population.
Total population.
PEB has, I want to say, around 30,000.
I would say it's closer to 45,000 total.
This one hurts my heart. I was on the original team that built this. And I remember when the team came to me, they were a little like, hey, Lou, we don't think this is a good idea anymore. And It's not. It served its original purpose. We got the information, the learning out of it. The leverage definitely changed on the table, and we're unable to get the savings that we were getting originally. So I understand, but it's weird to sit here on both ends of it.
I think the only, this is Megan Atkinson, with the Healthcare Authority. I think the only thing that I would, caveat here is, you know, and Robin, mentioned this when she spoke earlier, really the Governor Inslee budget is probably what we would call our high water mark, for budgets as we move forward over the next, 4 months of legislative session. And so when you see items like, you know, closing the UMP plus plans and savings associated with that, savings that are assumed, Governor Inslee, budget, undoing a savings item from the Governor Inslee budget essentially requires cuts somewhere else, right? Because he balanced his budget using cuts and using a fair amount of new revenue. And I think what we've seen in the Ferguson administration budget priorities, while it's, you know, only a document and not a full budget proposal, is, you know, commitment to go to budget reductions first. So as we move forward over the next several months, I anticipate the agency will get instructions to do budget reduction scenarios, budget reduction drills, and we will receive budget reduction targets. So a certain amount of our funding, you know, to identify savings equal to a certain amount of our funding. And as Tanya was mentioning, we oftentimes don't think about the PEB and SEB programs as being funded with general fund state, because as they show up in the actual budget appropriation bill, they're not coded to general fund state. But on the back end, obviously the money that's allocated to school districts for employee benefits is largely general fund state. So then the source of the SEB program is about 80, I believe 80% general fund state. A moment ago. On the PEB side, it's closer to about 40% general fund state. So as we work through the next few months and have directions on budget reductions, identifying savings for general fund state, you might see headlines or instructions coming out that are focused on general fund state, or what Robin called near general fund state. Just to understand that the PEB and SEB programs are still going to be subject to those reductions, because sort of on the back end, the point of origin, they're heavily funded by general fund state dollars. So you know, we'll see what the legislative budget proposals come out with. There was a significant amount of savings associated with this assumption of closing the UMP Plus plans a year early. I think, again, strange things happen during legislative session, but undoing that, again, would take cuts.
The last thing I'll should highlight about the budget is the implications of the collective bargaining agreement. We said earlier, Lou asked, like, what's the cost to maintain the current the status quo, if you will. The collective bargaining agreement is funded in Governor Inslee's budget and was listed as a high priority within the priority documents of Governor Ferguson's budget priorities. And the price tag of those is several $100 million. I believe it was
It's for healthcare alone.
just for healthcare alone, between PEB and SEB, both represented employees, and when the number, if it is and historically has been applied to non-represented staff, it was close to $900 million for the healthcare components to continue the status quo 85-15 split on the EMC between two collective bargaining agreements. And so you don't see that number on this page, but it is an inherently large aspect of the cost of the program and cost to the state. And another piece to highlight with that is while the PEB and SEB programs certainly are not insulated from budgetary pressures, there are certain components that are protected by the collective bargaining agreement and make some of the changes, you know, maybe have a longer runway in order to implement, that could be cost modeling. It's harder to do certain kind of targeted pieces that target certain benefit design in some instances, for example. That's why you see things like pulling from reserves and closing a plan as kind of the first level of things that are easier to do in the legal construct that surrounds PEB and SEB benefits. But they're certainly not immune, nor could this be the only thing.
Dave, is that 800 or 900 million just the employer share, or total computable between that and the premiums?
That was just the employer share.
So there's another 150 million on the employee side that's going to be spread throughout the premium structure.
I think we'll see some of that roll through on our next slide here. So on the next slide, we have the proposed funding rates for the upcoming biennium. Just for reference, the current funding rate is around 1170-ish. So you'll see that these have increased a bit. And what these take into consideration is funding for the decision packages. Those changes to collective bargaining that Dave mentioned, including the new FSA contribution, which will be included in the funding rate. So there's not going to be a separate invoice for those. And then our agency request legislation around the hospital pricing and the affordability, which actually puts a significant downward pressure on these rates. And then the Governor Inslee deficit proposals with the long-term disability and the UK Plus plan closure are all included in these funding rates. What will happen is I'm working on another quarterly update for the legislature, which will include another quarter of claims experience, updates from the open enrollment that just occurred, and another full set of assumptions that will go to the legislature for their final version of the budget, and they'll use that new baseline assumption for their modeling. So these numbers will most likely change by the final conference budget. But again, I'll bring those back once we have some more information. Any other questions?
All right. Thank you, Tanya.
Yeah.
Appreciate it. Okay, if you want to take 5.
I feel like 5 might be good.
Reading the rest should be good. Maybe 5, 10 minutes. What do you think, Larry? Which one? 5 minutes. You called it. Let's go. All right, folks, we're back, and Kelsey Pele, the Senior Account Manager in the IRB Division, is going to present an upcoming benefit addition to the FSA, which is our flexible spending account, or flexible spending arrangement. I always say account is an arrangement in the SEB program, and the materials behind tab number 7. Welcome.
Thank you. Good afternoon, Chair McDermott and members of the board. Like Chairman said, my name is Kelsey Kelly, and I'm the Senior Account Manager for the flexible spending arrangements and the dependent care assistance programs for the PEB and SEB programs. All right, next slide. Before I dive into the specifics of the SEB CBA FSA, I'm going to abbreviate collective bargaining agreement and flexible spending arrangement. I want to just take a step back and go over the core structure of the FSA benefit and the plan design that is offered to our school district employees. Next. Okay, so the core structure of the FSA, it's a tax saving program that allows FSA funds to be deducted from employees' paychecks before taxes to reduce their taxable income. So some examples of eligible out-of-pocket healthcare expenses that employees can use their FSA on are deductibles, the copay, co-insurance, prescription drugs, first aid supplies, sunscreen, vision hardware, and much more. Employees can elect a maximum of $3,200 in FSA funds for the 2025 plan year, or a minimum of $120. The election amount is subject to annual Internal Revenue Service IRS cost of living adjustments, and funds contributed by an employer do not count towards the maximum allowed election amount. The FSA benefit uses the carryover plan design, which began January 1st of 2023, and this allows unspent funds to be carried over and made available for use in the next plan year. The carryover limit has increased for plan year 2025 in the amount of $660. This will be made available for members in January of 2026. And it's an increase of $20 from this year, which is $640 for carryover that will be made available in participants' accounts right now in January of 2025. So as you can see here, the carryover limit increases every year and will never decrease. For FSA participants to receive carryover, they must enroll in an FSA for the following plan year or have at least $120 left in their account on December 31st. So any funds below that 120 mark, if they do not re-enroll or above that 660, regardless of enrollment status, will be forfeited to the HCA due to IRS rules. And then I'll also call out that each fall, the IRS sets the new carryover limit for the next plan year.
And is there a period of time the carryover needs to be used by, or is it for the entire plan year?
Entire plan year.
Is it always like that?
Chairman, are you remembering the other structure of FSA that we used to have before 2023, which was the grace period rule, where you had a certain amount of time to continue to spend funds, but moving to carryover, it's a potentially smaller amount that is permanently rolled over.
Cool. Yes, I forgot that.
All right, next slide. Okay. So I went over the general FSA basics, and now we'll kind of dive into the SEB collective bargaining agreement FSA benefit that will take place during the 2025 through 2027 CBA cycle. So the SEB CBA FSA benefit was bargained for eligible school employees to receive a $200 FSA. This benefit is not under the board's authority, but instead it is under the agency's authority. And HCA designs this benefit to ensure compliance with the collective bargaining agreement and contracts with Navia Benefit Solutions, our FSA DCAP vendor, to administer these benefits. Navia Benefit Solutions creates and manages members' accounts. SEB organizations play a key role in communicating this benefit. And this agreement will only become final if it is determined to be financially feasible by OFM, Office of Financial Management, and funded by the legislator in the 2025-2027 budget.
And this is just a quick reminder about the authority piece. The authority of the program is very complex. We say we have a set program. There are parts that are carved out for the legislative singular swim lane. There are parts where there's overlap of that swim lane with the board. The board has general benefit design authority subject to the funding questions of the legislature, but there are certain benefits like FSA DCAP that were statutorily created as the agency's authority on benefit design. That's actually a vestige of one of those benefits was originally administered by the Department of Retirement Systems, and they got relocated. And so that's all FSA DCAP statutorily is under HCA's administrative design authority, but we like to keep the board apprised of all the benefits within the portfolio of the program.
Right, so now we'll talk through the eligibility requirements for SEB employees to receive this $200 CBA FSA contribution. So employees must earn $40,000 or less for the state fiscal year prior to the plan year as reported to the Department of Retirement Systems, DRS. Employees must also meet SEB program eligibility requirements on January 1st of the plan year, and they cannot waive medical coverage except to be a dependent on another SEB non-high deductible medical plan. And then recipients also cannot be enrolled in our UMP high deductible plan.
And for clarity, these are all requirements that are specifically in the collective bargaining agreement. That first one's a little bit to unpack because it involves calendar year, state fiscal year, which are not the school year. And so, I know there are multiple different years to think about, but what we really are saying is, for example, I think maybe Kelsey might steal a slide from your future, but the first time this benefit would go live, it would be January of 2026. It would be based on the eligibility of that individual in January of 2026 with a salary threshold that is evaluated by HCA in the fall of 2025, which is really using data that is from July 1st of 2024 through June 30th of 2025. So it kind of straddles school years, but it's based on the reason the DRS data was selected as a good proxy, because all we were looking for at the bargaining table was a reasonable proxy on salary. A salary snapshot was we didn't want to create more work for the Healthcare Authority and benefits administrators to report salary information to the Healthcare Authority when there are already plenty of places that benefits administrators and districts report salary information. In addition, salary information goes to DRS for purposes of helping with the average final compensation compensation calculations for their pensions. And so there is a fairly robust auditing and cleaning up of that data. And so the idea came to leverage that state data. And again, it's not designed to be a perfect proxy for current salary. It is a snapshot in time that would be used for eligibility. So, but I did want to highlight that there was a specific thought of, does the healthcare authority need to become the keeper of state school district employee information? And no, we did not want to become that, nor did we want to burden districts and add an additional layer to the reporting that they already have a state entity. So that was very purposeful and something that OFM and HCA were talking about as this was being evaluated.
It's really unfortunate we couldn't incorporate the federal fiscal year either. Just for federal fiscal year, state fiscal year, calendar year, plan year on their school year. Yeah. Wow. Okay.
Thank you, Dave. All right, next slide. So HCA and Department of Retirement Systems, like we said, work together to determine the eligible number of school employees who will receive this benefit. In late 2025, the DRS sends HCA school employee salary data about non-retired active and terminated K through 12 school district, tribal compact school, and educational service district employees and their retirement plans. And then HCA will then apply that $40,000 limit to the salary data and compare it with January 2026 enrollment information to determine which school employees meet the eligibility criteria. And then HCA sends a final eligibility file to FSA, our FSA administrator, Navia Benefit Solutions, in mid-January, and they will make available that $200 contribution to eligible employees. In this slide, I'll kind of talk through how the participant will receive the $200 in January of 2026, really how it works on the employee side. So in late January, early February of 2026, Navia Benefit Solutions will send out a welcome letter to CBA FSA recipients that explain how to use the funds, why they're receiving this benefit, when to expect the FSA debit card, what to look out for in the mail, and how to manage their account. New recipients will get a debit card that they can use to spend their FSA funds on eligible healthcare expenses right away. And participants will be able to use Navia's portal to manage their FSA benefits, and they can also submit claims for reimbursement. Eligible FSA, CBA FSA recipients, they're not required to actively enroll in an FSA to receive this $200. But if the recipient did actively enroll in an FSA during the annual open enrollment period for 2026, the $200 contribution will just be added to their existing account with the funds they elected. This slide depicts the Navia Benefits debit card that I mentioned in the previous slide. So new FSA and or dependent care assistant program participants and existing participants with an expired debit card, I think cards expire every 3 years, are issued this debit card here, the Navia Benefits debit card. With having the HCA icon and the PEB program and SEB program written language on the top of the debit card, this really helps SEB CBA recipients make the connection and recognize that this debit card is not just another scam coming in the mail, but part of a real benefit offered by the SEB program and their employer through Navia. Also, the logos can help members actually retain the card and use it on eligible healthcare expenses, and recipients receive their welcome letter right before receiving this debit card in the mail. So the intent is that they read their welcome letter that explains the benefit, why they received it, look out for this debit card in an unmarked envelope in the mail, and then they receive the debit card shortly after.
But have no fear, Kelsey, because if they still think it's a scam and throw it away, they can get a replacement card for free.
Absolutely. All right, next slide.
I mean, because so many times have we all gotten something in the mail where we're like, too good to be true.
Yeah.
We
thought that a lot.
It's funny, Anna, but how regulated the little pieces of plastic are in all of our wallets. But this is not the first iteration of these cards. This is the most recent iteration. It has taken quite a lot to get our own iconography and names on these types of cards. But those were important steps that have been made in the last couple of years to really help drive down the perceived concern about a scam and ban.
We had an HCA employee recently win a 3 years worth of groceries, Safeway. He didn't have to enter just by using his card. He automatically entered. They called him for 6 weeks straight to try and shove this year's worth of groceries down his throat. And he was like, "It's a scam. I'm not doing it. It's a scam." And then finally he called Safeway and they're like, "Yeah, you won. We've been really trying to get hold of you." He's like, "I just can't believe I won." Yes.
On the flip side, if you ever get an email, because we have had this in the past, but if you get an email that suggests Sue Birch or Mary Ann Lindblad wants you to bring gift card to the board meeting,
don't do that.
Do it. That has happened in the past to Pebble board members.
If we're getting,
I don't understand how that scam works, but
if we're getting to the point fiscally where we need board members to bring us $400 in gift cards, that's what this quit. It's over.
Okay, this table here depicts how the carryover design will look for a SEB CBA FSA recipient who does not make any personal elections. And this and in this example, we assume the current 660 carryover limit and the $200 contribution does not change. So across the table, across the top of the table, you can see each year the member is eligible for that $200. In year one, the $200 is deposited into the recipient's account. This person does not spend any of their $200. And he has never had an FSA before in the past, so the ending balance is $200. And year two rolls around, that $200 carries over and another $200 is added for a total of $400 in this person's ending balance. Again, this person doesn't use any of the funds. So then year three, all $400 carries over in the beginning balance, and then another $200 is added. And this person now has a total of $600 in their FSA, but they still don't spend it. Year four, all $600 carries over, but it's still less than its 660 carryover limit. And then another $200 is added for the year. This person now has $800 in their FSA, but they still don't spend that money. Since $800 is over that 660 carryover limit, the person forfeits $140 to HCA due to IRS rules. And then year five and beyond, only 660 of 800 carries over. 200 is then added for a total of 860. But we will have to forfeit $200 due to IRS rules. And then year six on beyond again, 660 of that 860 carries over. So this person forfeits additional 200 going forward.
So a good thing about this structure is it can take, for somebody who has never had an FSA benefit, doesn't believe that this is a real thing, throws away their card and has to get another card, or forgets about it year after year. They have 4 full years under this scenario where they haven't engaged, don't know what this benefit is, haven't used it before, completely unfamiliar, before they have any potential forfeiture related to this. That's one of the advantages of moving to the carryover rule. This is a benefit that's been in the PEP collective bargaining agreement for 1 or 2 cycles, and the shift from the grace period rule to the carryover rule helps in this exact scenario with somebody who's unfamiliar with the benefit, and is a purposeful design that kind of encourages maximum potential employee access to this benefit. So just wanted to draw attention there.
What if they fall out of eligibility? No longer, they make over $40,000 in a year.
They fall out of eligibility.
They don't get the new
They just
200.
don't-
Yeah, that's right. That's right.
200, the initial 200 just carries over.
Yeah, whatever year they stop in, that doesn't claw back the prior contributions. It just prevents additional future contributions, but it would continue to carry over. And in theory, let's say that somebody was eligible for the first 2 years, had $400 in their account, went over $40,000 and never engaged the benefit. That 400 would just kind of perpetually roll over year after year after year, as long as they were still a SEB eligible member. As long as they were still in SEB eligibility.
Is this regardless of their employee contribution? They carry over the 600 and a 600 from their employee contribution?
It's a total cap of 660 for this upcoming year, regardless of the source of the contributions.
Yeah, what if they're no longer employed?
They'll still be able to use it.
Well, up
until their employee end date.
Yeah, up until the end of their employee end date, but there are COBRA, you can COBRA your FSA. It's unusual. There's a lot of reasons why most people wouldn't do it, but there are circumstances where there are. So, but there is a point where when you no longer are benefits eligible, that your access to the FSA can end if you haven't COBRA'd.
Right. All right, next slide. Okay, so now we'll just dive into some operational insights for this benefit. Next slide. So first, just to look at an approximate number of how many SEB CBA FSA recipients that could be eligible for this benefit come 2026. This is based off of school employee salary and SEB program enrollment data from fiscal year 2023. So approximately 29,000 school employees would have been eligible for the CBA FSA benefit in 2024. All right. Lastly,
Are districts notifying the employees personally that says you're eligible for this and you're not taking it, or what's going on that it's not?
that's kind of in my, yeah. So lastly, I want to discuss the communication plan and key messages. We are going to really be mirroring how we communicate this benefit as we do on the PEB side. So a few key messages we will communicate in all of our messaging be briefly explaining what an FSA or flexible spending arrangement is and how to use the funds. We will communicate the eligibility criteria for the CBA FSA benefit and how the benefit was established, such as being a union negotiated benefit during collective bargaining. We will also communicate how carryover works with this benefit and what happens to unused funds at the end of the plan year. We will explain that recipients will be automatically enrolled in the CBA FSA if eligible, and that no action is required on the employee's part. And just making sure that they know this doesn't come out of their paycheck. We will communicate that new recipients will receive a debit card and instructions in that unmarked envelope, and briefly describe what the debit card looks like. And then lastly, we'll communicate who to contact with questions. So Navia Benefit Solutions for general FSA questions and how they can manage their account, get into their portal, and then go to their employer for specific eligibility questions they might have. Next slide. So I think this will help answer your question. This is an approximate timeline of for when we'll introduce and roll out this benefit to different stakeholders this year and in early January. So starting this month, the CBA FSA will be incorporated as an agenda item during the SEB labor quarterly meetings and during the SEB organization stakeholder meetings that happen throughout the year. And then in March, we will introduce the SEB CBA FSA to all benefit administrators by email, and we'll also put it on the SEB Benefit Administrator FSA DCAP webpage. And then we will also create the CBA FSA toolkits for unions and for BAs, benefit administrators to use. So that's just a document that is a compilation of different types of communications available for these stakeholders to use while communicating this benefit to their employees. And then in May, we will introduce the SEB CBA FSA benefit in our May SEB employee newsletter. And at this time, we will add the SEB benefit, the CBA benefit to the HCA and Navia web pages and post the final toolkits on the SEB BA webpage and email that link to SEB BAs. And then in the October-November timeframe, we will have open enrollment messaging for BAs and employees, such as an article within the October SEB employee newsletter and also forwardable messages. And then in January 2026, Navia will send that welcome letter to eligible SEB CBA FSA recipients and the debit card in the unmarked envelope. And then we'll also send out a Gov delivery message, which is just an email to SEB benefit administrators at the end of January to remind them that some of their employees may be eligible for this benefit. Next slide.
We are also primarily this is communicated from HCA as the administrator of this particular benefit, but there will also be things we anticipate the unions will want to promote about it as a feature of the collective bargaining agreement that was added. And there's a fair amount of collaboration to be able to have communication tools that they can use as well as benefit administrators. When we began talking about this in our BA stakeholder, SEB BA stakeholder group, there was a request that, we're modeling a lot of this is how we administer for PEB, and we just didn't have this question. I was like, oh yeah, that's a great point, which was SEB BA saying, well, can we have the list of employees that you sent to Navia so that we can help make sure that we can answer questions on the front line, if you will. We direct the employees to start with their home HR benefits administrator department departments. And so, yeah, looks like that's a great point. We will look into adding that into our work plan now that that's been raised early enough, because it should be a fairly simple extra data depot file drop off for districts to have that list too.
Sorry, what did you say was the evaluation period of the earnings? Did you say it was July to June?
Yeah, it's the fiscal year prior to the plan year in which we're talking about. So if we're talking about a benefit in January, you're talking about the evaluation happening in the preceding fall based on the prior July to June snapshot, which does straddle 2 school years. So for example, the scenario where on the slide where Kelsey said 29,000 individuals, that was looking at as if we had made the benefit go live January of 2024, which means we were looking at a snapshot of salary from July of 22 through June of 23, and pretending that we were applying the eligibility in January of 2024 that salary threshold. And this question, an underlying part or a follow-up question that often gets asked here is like, well, what if somebody's salary changed before or after that? The criteria is based on that snapshot. It is a snapshot if you went above it or below it after the fact. It's based on what that snapshot is. And so if there's a question about the underlying data, then we would ask people to work and understand how their data is being evaluated at DRS, because that should also be cleaned up if there's an issue. But the snapshot of data is a single point in time. It's not designed to be perfect. And there's an acknowledgement like this is a new data source. On the PEP side, we actually don't have the salary information for state employees. OFM does that part of the equation, and then they give us a subset of state data, and then we apply the eligibility plan piece of the component of eligibility. Here, we're going to be doing the eligibility, both parts of that evaluation after we get an input of data from DRS. But it is not designed to be a perfect representation of salary. And as we use that data set, and we will have pros and cons to it, and that may require adjustments to how that's done in the future, which would also probably need to be discussed with that party.
So is the $40,000 whether you work full-time or part-time, it's just $40,000?
Right.
And when you did this on the PEP side, did people get confused between their voluntary contribution, how the program works for the voluntary contributions versus this one that came to them?
No, many on the PEB side, I think about 90% of the folks that are eligible on the PEB side, they don't actively enroll in an FSA. So they just get the straight 250, every year that they're eligible. But
just magic that comes to them, and then other people actually know you can create magic in addition.
And our job is to really just make sure they know they have that magic available to them, and use it.
The one question that came up after the first year of carryover was, whose dollars were spent first? Was it my dollars or was it the employer dollars? And we're like, well, and we answered some questions around that, but it's a very small set of the population, and it's really a singular pot of money. And what's the contribution ends up in your account, so to speak.
Right.
Just looking forward, to open enrollment, one thing I can anticipate happening is having employees come to us with the question of, am I going to be eligible for this? So, we look at school, salaries in a school year basis, not necessarily, we report it to DRS, but not necessarily in their fiscal year. So it just makes evaluating whether or not an employee is going to be eligible for this benefit a little hard. So I could just see that being a bit of a frustration for benefit administrators of not being able to tell an employee during open enrollment with certainty whether or not you will receive them.
Yeah, and HCA is unlikely to even have the data from DRS, but definitely not before open enrollment occurs. It begins, and probably not until after open enrollment is ended. But I think part of the underlying piece of your question might be is if a person's trying to figure out how much they want in their account, can they reduce their election based on the reliance that they think this money is coming? I don't, especially this first year, it's going to be, there'll be some people that you feel reasonably sure probably will need it. And then there's going to be a lot of edge cases where it's just going to play out with what the data, how the data was reported previously. It's going to be, you're right. It's going to be very hard to be able to predict it, especially in year one.
Other questions or comments from the board? Kelsey, thank you so much. Appreciate it.
Thank you, everybody.
Don Barton, are you with us?
I am. Thank you, Chair McDermott.
Oh, John. I'm sorry, dude.
Well, I'm glad you can at least hear me.
This reinforced you staying away from the building today.
Well, this one.
So this is part of the retreat where I usually share two processes that we run within employee and retiree benefits, one being the contract renewals and one being the benefit planning cycle. These are being handled a little bit differently this year simply because of, as we heard this morning, the budget deficit that we're facing over the next two biennium. And as Dave echoed, from Robin, Dave echoed that, Tanya echoed that. So we're managing these a little bit differently this year, given that we don't expect, if we go with an ask for a true expansion, needing funding for expansion, it's pretty unlikely, we believe, that that's going to be received positively. So if we flip to the next slide, I typically talk.
John, I'm going to go ahead and remind people behind tab number 8, and what we're talking about is sort of the planning cycles for SEB. So continue, sir.
Sorry, thank you. There are a number of influencers, if you will, to what benefit designs we offer and consider. The board, obviously, is one of the key ones. We've got the executive branch, we've got members and labor partners. We've got the legislature, and then of course we have the federal government, which is kind of they're telling us things, not necessarily taking our advisements. But all of it points back to we've got to have the funding for it. So again, given the budget environment we're in, we're not anticipating that it's going to be a terribly rich year or years to ask for increases. I normally would go over both of these cycles. I've included them in the appendix to this presentation. If anybody has questions, feel free to reach out to me. But the one thing that I will point out is both of these cycles typically run about 18 to 24 months from beginning to end. And that's because we generate an idea, it's got to receive funding and legislative backing. And then once we have the funding, we can start planning towards implementation. So it's an extended runway for these. So if we flip to the next slide, for this year on the contract renewal cycle, these typically are for existing relationships. So we've already received funding to offer some sort of benefit or purchase services. And we're simply asking for renewals. And we ask them to both bid for the renewal, and we ask them what kinds of things are they seeing in the claims experience that might suggest other opportunities or modifications to the benefits that might be useful for our members. So we'll run it largely as normal, but we will be communicating much of the financial forecast that we heard about this morning and using that to manage expectations with these contracted partners. But we'll still be trying to gain awareness of what innovations they're creating and assess any future opportunities so that we don't just miss that ability to review what's out there in the market. And then the next talks about the benefit planning cycle, which is what we do in benefit strategy and design. We'll be using a streamlined process given the financial environment, the fiscal environment that we're in. We won't be soliciting for new ideas. We will be reviewing those that we've generated previously that had relatively low price tags that we might be able to still move forward with, that were reviewed positively in the internal review processes, but just didn't make it in the prior rounds, prior cycles. We will continue doing our industry scans like I talked about with the contract renewals. So we're staying aware of what's out there, what kind of innovations are occurring, and hopefully that we're not missing anything major or giving us ideas for things that we should be working on for future cycles. And then we'll also review benefit additions that we've made in the last 5 or so years that have had much lower than expected utilization. So we forecast the expected utilization when we do the write-ups on a benefit addition. And that's true of either of these processes. My apologies. But for those that have been implemented and we're seeing much lower than expected utilization, it doesn't mean that the idea was a bad idea and we want to just get rid of it. It could mean that we need to build, awareness and educate members about the benefit. So that's one potential outcome of that review. Another would be, are there refinements that we could make to relatively inexpensively or, in a net neutral way to those benefits that would make them more valuable to members. And then we'll, based on those reviews, make decisions, not just my team, but as a agency, which ones we want to push forward, or as a division, which ones we want to push forward and try to either gain additional awareness and utilization in, or ones that we think we should be looking at doing something different with, or swapping out for something different. Like Dave was talking about earlier, sometimes if we have something we can do away with. Now, remember, these are not being utilized as much as we expected. So the chance is they're not going to have huge price tags currently. They may, but it's unlikely. So it may take several of these to fund something additional. So that's kind of what we're focused on right now. My team is working on that. They've got the list of additions. We're sizing which ones have underperformed in terms of member utilization. And then we'll circle back with the other parts of the division to discuss what should we do next with these. Forgot to mention at the reviewing those that had been previously proposed with a lower price tag. There are a couple of those, right? And one of them was talked about earlier with doulas. We've done a full write-up on what we think should be done with doulas. But as I think Tanya mentioned earlier, there are some operational challenges around that benefit. And so while we support it definitely from a BIPOC community support perspective. There may not be sufficient network and it may not be in the right areas to see that benefit. And so we'll continue to advise on that and work as there's a statewide work group that's working on how to cover the services, what services should be covered, how they should be billed, how they should be reimbursed. So we'll continue to participate in that work group and see what's happening with the network development. And then we'll also work with our payer partners to see how they plan to implement, since it, in theory, may apply to them. So that's kind of in a nutshell what we're doing. Again, I attached the two process maps so that you can see them if you have interest. If you review those and have questions, feel free to reach out to me, hopefully after I've regained my voice fully. And I'd be happy to talk through it with any of you. So I'll pause there for any questions. I went through that fairly quickly, trying to avoid you listening to me coughing.
I'll just highlight for board members, this is usually the presentation where you say, what are your hopes and dreams and desires? But given the budget context we're in, and what John just says, how we're refining that process, we know what the typical hopes and dreams and desires have been from recent years, and we're not going to engage in starting that process this year on this context. So just putting a real fine pin on that. And then after we do a final check for any questions, John, when we're done this presentation, please sign off for the rest of the day. You earned it. Thank you.
Thank you, Dave. I appreciate the fill in there.
Any questions from the board? John, go to bed.
I appreciate everyone's patience and attention.
2 presentations today and above and beyond. Thank you, sir.
Thank you all.
Yeah, bye-bye. He's a sick dog. All right, next up, Actually, we had a break scheduled, but we just took a break. Is anybody feeling like we need a break? Keep hitting it? Okay. 58. Stakeholder engagement coordinator in Herb is going to go over the results with us from a recent engagement survey.
She is.
Okay.
Hello, can everybody hear me okay?
Yes, we can.
Awesome. All right.
Yep. Her materials behind tab number 9. Welcome, Missy.
Thank you. Good afternoon, Chair McDermott and members of the board. For the record, my name is Missy Yates, and I am the Stakeholder Engagement Coordinator for the Employee and Retiree Benefits Division here at the HCA. I'm here to give you a summary of the results of our active employee survey from June of 2024. Next slide. This survey was designed to serve as a baseline for future surveys and then also a catalyst for maybe future engagement opportunities with our active SEB employees and members. We're going to go over the background of the survey itself, talk about a few key takeaways from the results, even talk about some of the demographic voluntary responses we received, and then answer any questions or have any discussion you may want to have. Next slide. So our survey had 26 questions. We had this survey open for an entire month in June of 2024. The survey was for all active employees in both the SEB and PEB groups. We had 2 questions about subscriber status of which group they were in, their status of whether they were full-time, part-time, seasonal, and then also whether they were, questions about their satisfaction levels about different benefits within their own packages. The majority of responses were from the SEB side, but we had 91% full-time SEB responses. There were about over 2,800 people responded. 8% were part-time, that was around 248 people, and about 1% of our seasonal and temporary employees in the SEB program responded, which was a really good response for us. I thought that was a really hefty amount of people that responded in this. Overall, you can see here we had 3,100 responses from the SEB group out of the 5,000 responses overall. I also had 6 optional demographic questions, which we'll talk about near the end of this presentation. Next slide. So the survey gave us a lot of information about member satisfaction. Some of it was not that surprising, but it was great to hear from people themselves on what they felt was important to them, and we gave them some opportunities to actually write in some comments as well. So it was interesting to watch the responses come in. The next few slides you're going to see have a few key elements regarding the SEB employee satisfaction on various areas of healthcare benefits that are offered in this program. Next slide. So we asked subscribers, what are your top 3 benefits in terms of importance? And then what are the top 3 factors that you considered when choosing the current health plans that you're enrolled in? And these are the results on the SEB side. And of course, again, not too surprising, medical, dental, vision is your top 3 most important benefits people consider when looking at employment and what kind of benefits are offered. And then when choosing the current plans they were in, their top priorities was how much does it cost, what type of benefits and coverage they're going to get, and also what type of providers are within the network and can they continue with the providers they're currently seeing. Next slide. So I wish just to preface on this slide, the direction of satisfaction, if you're having any trouble with the colors or anything or understanding this, the direction of satisfaction moves in a clockwise direction, starting with that 13% in medical, 15% in dental, vision, 11% satisfied, very satisfied to satisfied, and it goes all the way around in a clockwise to neutral, dissatisfied, very dissatisfied, and not applicable, just so you have a reference of how these pie charts work. more than half of our SEB survey participants seem to be satisfied or very satisfied with their medical and dental benefits, while less than half of them indicated they were satisfied with their vision benefit. Next slide. When we asked them about overall satisfaction of all their benefits and the comparison of their out-of-pocket costs to the benefits they received, more than half of SEB's participants indicated they were satisfied or very satisfied overall, while just a little over a quarter of participants indicated they were satisfied with the cost compared to the benefits received. Next slide. So we hope to, as I said before, use the survey feedback to help us look for future opportunities for engagement and further discussion, but also we want to use this to inform us in ways that we can figure out ways to improve our communications and ways we can engage with members moving forward. So we asked a couple open-ended questions about what people thought would help improve their levels of satisfaction that they provided in this survey, and what things were most important to them that we thought could be changed, they thought could be changed, and why. And these gave us kind of a list of what we thought were probably the biggest pain points in members' eyes. And you can see here, and these are not in any particular order, they're just a list of things that came up most commonly in the comments. But cost was probably the most common, with being able to see the cost before going to a doctor, the increase in costs, as you know, everybody is concerned with costs. And then they go through other things like having the ability to find information about their benefits, what types of prescriptions are covered, timeliness in getting to see a doctor or having their claims processed or getting appointment scheduling taken care of. And it goes down through the list. Customer service, that applies to all areas of healthcare. That includes customer service from their HR or benefits administrators, customer service from the carriers, customer services from HCA itself, and customer services from their healthcare providers. So there were comments across the board for various areas for people having comments about whether or not they were getting good customer service from all areas related to their healthcare benefits. When it comes down to the later part of this list, provider network limitations and concerns about being able to reach a doctor or get access to a doctor being limited based on geography, long wait times for specialty care appointments, and also limitations for the networks when you have things like college students outside of the state trying to get access to a doctor, or when their members are traveling, things like that. So there was some comments regarding those things. And then of course, we have the technology, people complaining about having too many different accounts and too many logins to remember to access all the various benefits. Each carrier has its own login. Login's not working, and that could be HCA's SAW account, the state SAW account, or even other things at the carrier's level trying to get into an account. And then things like enrollment forms, or maybe even the Smart Health app not working properly or as expected. And then also dual coverage rules, having that ability to be covered by having a spouse and yourself under the same plan or different plans, and all the rules that are involved with that. Next slide, please. So one of the things we found a trend towards was some questions about healthcare literacy. How much do people feel comfortable with understanding healthcare plans and how they understand how things work? And so we had some questions around that, and you can kind of see the percentages of where people are comfortable as far as whether they feel they have an access to enough information to make decisions, whether they felt like they could understand their benefits, being able to access plan choices that met their needs, and also feeling that they thought their benefits were easy to use. And those percentages kind of get lower as you go down this list. So this is an area where I think we've talked about in the past, but it's also an area where we could focus and have better communication about where can you find those resources more easily. And we can also communicate and publicize more of those areas where we do have educational resources or information on our website or other places where they can find that information more readily at their fingertips if they need it. Next slide. So we had a question where we gave gave a place where people could pick up to 3 places that people go for their information. We said pick out of this list of places, what are their top 3 choices? And so you can see here the most common place that people go to get help about their insurance is their insurance plan, the carriers. But they also go to their healthcare the healthcare authority's website. They go to their HR, their healthcare provider. That third one there is healthcare provider. So there's multiple places that people will go to get help. And then I do have an appendix page at the end of this for that other. So please describe. We had an open-ended question there where we allowed people to write in stuff, and you'll see those answers at the end of this slide deck where people put in a lot of different answers there. So I provided that for people to see that as well. Interesting note for this area here. A lot of people, again, said that they go to their insurance plan. That was prominent for both PEB and SEB members. My employer was the second most selected option for SEB, closely followed by their healthcare provider. But in PEB, their second most selected option was HCA's website. And I'm thinking it might be because SEB's newer to HCA, and so it's not utilized as much, or it's maybe not popularized by, or maybe not provided to members as often as a resource. And it could be something we could share out more often through the BAs or other possible ways. I'm not sure. It's stuff that we can be talking about, and we'll consider working with the BAs even more to try to encourage members to utilize the website more to find the information people are looking for. Next slide, please.
We have a question.
Oh, okay. I'm so sorry. I didn't see a hand.
I was just wondering, I see that the HCA's website says 721 and then coworkers was 741. Do those need to be reversed?
Oh, I'm sorry. I was wrong about that. Yeah, the coworkers and friends on the SEB site was the fourth one. But that's what I was trying to say was HCA's website was much lower on the list of selections for SEB than it was for PEB. PEB's when we looked at PEB numbers compared to SEB, HCA's website was number 2 as the most highly selected area for people to go. So it actually beat out the HR and the healthcare providers, and it was the second most suggested. So on this one here, yes, the coworkers and friends or family kind of thing, those were more, it was more selected, even more so than the HCA website, which is why I said we probably want to promote our website a little more, because it does have a plethora of information about the programs, about the benefits, and how to use them. And there's a lot of great information out there. I just don't think folks know where to go or how to get to it, or know that it's there to be able to utilize for them to be able to learn more about their benefits. Good catch. I apologize for that error. So another one we had, as we were looking through some of the comments, we pulled out some of the comments about people and things that they thought would improve their experience with their benefits, or their experience with their the concerns that they have. And these were just some groupings of areas we saw as like themes that regarding what people seem to desire to make healthcare benefits in this program better. And again, lower costs and fees, more benefits and more coverage. And you'll see here something we've already talked about multiple times today: weight loss treatments, infertility treatments, and additional benefits like that. Again, that accessible information, having a lot of people talked about not being able to find information when they looked for it, or knowing where to go to get help or find that information when they needed it. And then also process simplification. And that comes back to how that timeliness or having things made simpler. People have a hard time understanding why it takes so long for things to happen. And they think it needs to be simpler to understand and simpler to be processed faster. So that's another area where people think simplifying the process will make things better. Next slide.
Director thinks that there's things that can be simplified and should be better too. And there's a lot on the do list to improve things for everyone.
Yeah.
There's plenty of opportunity.
Yes.
Oh,
So
we have a question quick, Missy.
Oh, go ahead. Go ahead.
More a comment, actually. I think back to our presentation earlier about benefits 24/7 and the struggles here, and then kind of the theme here also about easy to find information or easy to understand, and then just the underutilization of the website in the SEB program compared to the PEB program, and just how important it is for the stabilization to occur with benefits 24/7 to help with that process with outreach and training and freeing up some of their time to be able to assist benefits administrators with that kind of outreach and training. We're extremely busy in that process, and it takes a lot of hand holding with our employees. And if we could get some additional trainings for member resources of just this is how you enroll, videos or those kind of things that are updated on a more frequent basis that school districts can do. But if the healthcare authority and outreach and training was able to provide some of those resources, I think that would help with the accessibility to information.
Great points. Thank you.
Yeah, thank you. So I know I did a presentation this time last year about a project that we were launching to begin working on a way to collect some demographic information from our members in the Benefits 24/7 system once it's stabilized. And as you heard Dave mentioned earlier, our prioritization is, of course, stabilization. So while we're waiting for stabilization to get completed and everything, we have still been working on that project. But during the survey, we decided to put some, I would say, high-level demographic questions, more of the standard short answer demographic questions as an optional section in this survey, just to see what type of response we would get, and also to kind of see how people responded not only into the questions, but also to get some type of feedback to give those write-ins to see, are we going in the right direction in terms of the kinds of answers we're providing in our other project. So it was very interesting to see what we'd collected there. So if you want to go to the next slide, the biggest thing we noticed was the participation levels and how they changed over the questions that we were asking, and the willingness of members to answer those questions. So the percentages you see here combine the not applicable or prefer not to answer responses. So this is the percentage of people when they were asked to answer these questions who answered not applicable, or they answered prefer not to answer. And you can see as we progress from a preferred language all the way up to sexual orientation questions, the percentage gets larger. So it's something for us to consider as we move forward with the race, ethnicity, and language project in Benefits 24/7 of what we need to consider as we move forward in those categories of how sensitive that data might be to the people who are answering the question, what we are using the information for, and making sure our members understand the purpose of the questions. So it just gives us some highlights into member participation at this point. Next slide is the questions section. So if you have any other questions, I'm happy to answer them.
Other questions or comments? All right, Missy, thank you so much. Appreciate your time today.
Thank you for having me.
Ms. Laura, are you gonna be in person? Hey, Laura. Laura Ryan, she is our retiree benefits manager in the IRB division. She's going to give us an update regarding retirees and the pet population and continued engagement efforts with the retiree population materials on tab number 10. Welcome.
Good afternoon, Chair McDermott and members of the board. Yes, I am Laura Ryan. I am the new retiree benefits manager, and I will be presenting some Medicare updates. Next slide, please. I have a little overview of what I'll be discussing today. First, I'm going to offer a brief introduction. Next, we'll discuss the open enrollment Medicare plan changes, provide a recap of last year's benefits fairs, and then some planned communication improvements that we have for 2025. And lastly, just a quick review regarding SEB retirees returning to work. Next slide, please. So I am the new retiree benefits manager as of the middle of last September. I came to this position from the Office of the Insurance Commissioner. I worked in the SEBB program for years, doing a lot of Medicare related work, advocacy, helping with escalated Medicare issues, things like that. I also, a few years ago, I worked here in customer service division in retiree customer service. So I have a lot of experience with the program. And then prior to that, I have over 8 years working in kidney care for a company called DaVita. Most people who dialyze are Medicare recipients. So good 15 years or so of Medicare experience. Next slide, please. I'm sorry, I missed one piece. I just wanted to mention that I had the opportunity of about 3 months of crossover with Ellen Fagan before her retirement. So that was a very valuable time where she was able to hand over work and lots of knowledge. So next we're going to look at some graphs showing the plan switching from our open enrollment season. This table here represents enrollment changes for members in the PEB retiree program who do not have Medicare. So these are folks who are retired but not yet Medicare eligible. So you'll see in the first column how many people were in that plan pre-open enrollment, how many post-open enrollment, and then lastly, the change. And you will notice with all of these numbers, the numbers have gone down, and that's simply because people were aging into Medicare and no longer eligible for these specific plans. Next slide, please. And this is a similar table, but this is going to show members who are eligible for Medicare. So these plans represent our plans that are only available to those with Medicare. So again, you'll see the pre-enrollment numbers, post-open enrollment numbers, and the change. You might notice that the Plan F enrollment is down, and that's simply because it is no longer open to new enrollees. And we've had members who returned to work, possibly passed away, or just and then this last bigger graph is simply a combination of the first two. So this is going to represent all members in the retiree program, whether they have Medicare or not. And again, the numbers prior, post, and then the changes.
Laura, just to highlight for the board a couple of things that one of the big things that stands out on these graphs whenever I look at them is I'm thinking about the year over year trends, which we don't have a specific slide that shows that at this point. But if you look at UMP Classic Medicare with Part D, that is the core plan that has for many years had over a majority of enrolled lives from the Medicare population. And then over the past couple of years, significant premium increases that were back to back, over 20% increases, were really driving migration out of that plan to the tune of 5 to 10,000 per year. So to see a net reduction in that enrollment of that plan under 1,000, actually under 700, is a significant reversal of the trend that had been happening over the past couple of years. And a big piece of that was last year because of the PEB board's decision upon the agency's recommendation to shift the formulary to a Part D formulary and leverage federal subsidies in a different way. That allowed for an actual decrease in member premium last year for the first time in 2 years. And it was a pretty substantial drop. I'm now thinking it was, I can't remember from actual dollars what the drop was versus what it would have dropped. I think it was at the tune of around $80 an actual dollar per month that was realized as a reduction in premium with minimal to no difference in benefit design. It was just kind of a restructuring of the pharmacy benefit of that plan. So, these are seeing that's really a key takeaway, was that there's, at least for moving into 2025, there was a much more kind of stabilizing effect on enrollment of that plan based on the trends that have been happening in prior years.
Then this slide is simply a different visual looking at the data that we just discussed. Then going through each plan carrier, starting with Kaiser. So we did have, it's been mentioned earlier, there was a service area change for the Kaiser Washington Classic Medicare plan. So this mostly affected Eastern Washington counties, and we had about 2,600 members that needed to change plans. Most of these members were already seeing a provider who is already in one of our other plans networks. We estimated about 99% of members were seeing someone who was not a Kaiser provider. So they were able to choose a different plan at open enrollment.
I'll just add here, it's atypical for people to think about Kaiser and the old group health as having external providers outside of their system, but that's exactly what this was in their Medicare space. They had two different plan structures, and one of them emphasized paneling non-Kaiser providers more, and that's how the kind of changing of that service and the service area didn't have as a profound impact on being able to see the same providers, because they already weren't seeing what someone would have thought of as a Kaiser provider. So it allowed that transition to be a little bit more smooth for the average member who was impacted by that service area change.
And then just a note about the communications, these impacted members did receive a lot of communication from both the HCA, but also from Kaiser to help guide them through the change. And then next we have the Premera Supplement Plan G. So this does continue to be a popular option. This did see an increase in enrollment this year from last year. And then just a note again that Plan F, Premera Plan F, is closed to new members, to new enrollees and to re-enrollees. But for folks who, well, I'm getting ahead of myself. I'll talk about this a little bit later. So we did have a Sheba presence at the benefits fairs this year, and that was really helpful for folks getting different Medicare information, but primarily questions about standalone commercial Part Ds. So if folks choose this option, then they're going to need to find a standalone Part D. And at some of the fairs, people were able to get enrolled right there. And next is the UMP Classic Medicare with Part D. So as we discussed, the premium did drop significantly from 2024. And there was a lot of positive feedback about that reduction, although we did still see a slight decrease in the enrollment. We've had general acceptance of the change to Part D prescription structure. We also had significant communication that went out ahead of time about that. And also, as we discussed earlier, there has been some technical challenges with this plan implementation, some of which are to be somewhat expected with a new plan, and we are addressing this as quickly as we can. And lastly, the United healthcare Medicare Advantage plans. These are certainly also very popular and saw a pretty significant increase in population or in enrollment this year. Let's see, for the PEB complete, it increased by about 2,839 enrollments. And for the PEB balance, it was just about 43 enrollments. And next, just a brief recap of the benefits fairs. So we have found that retirees continue to be the main population at these fairs. And typically the first half of the day is going to be the busiest with retiree interest and questions. And as I said previously, SEBB's presence was very appreciated this past year. We've gotten a lot of positive feedback about that. In response to requests to have more comprehensive retiree materials available for handout at future benefits fairs, we are preparing some changes for 2025. That's your education improvements. So based on previous feedback we had received regarding too much information and the need for simplification last year, our communications team did implement retiree-specific newsletters this past year in 2024 with a redesigned format. They also implemented a retiree-specific open enrollment webpage this past year. And as of this year, we have convened an internal work group that will identify and provide some simple communication resources that will be tailored to specific retiree groups. So these groups may be current retirees, prospective retirees, retiree who is eligible for Medicare, one who is not. So sometimes we find that these groups have very different needs. So we want to have some more targeted materials to help guide them through the processes. And then this past year, HCA also hired a new communications consultant who will focus specifically on retiree communications. And then lastly, this slide is just a brief reminder to information that's been previously presented at board meetings. SEB retirees who return to work must defer PEB retiree benefits if they become eligible for SEB employee benefits. They can, of course, return to the PEB retiree program when they're no longer eligible for SEB employee benefits. So if members were enrolled as a retiree in the Primera Plan F, and then they become eligible for SEB employee benefits, when they return, they will not be able to go back into the Plan F, but they will be able to choose Plan G, which does have the same coverage as F, with the exception that members do pay the part deductible Plan G. However, there are some premium savings that kind of make it almost a wash there. And
the one thing I wanted to add, because we have worked on the PEB side of the equation quite a bit in the last couple of years on the Medicare portfolio and specifically that UEP Classic Premium. And I just wanted to put a finer point on like the real life impact that work had. So I just looked up the numbers really quickly to remind myself of the premium last year for that kind of flagship UEP Classic plan was just shy of $533 a month. It was going to jump to $704 a month. But the change actually had and an additional federal subsidy that came into play in late July actually drove the premium down to just under $420 a month. That's a swing of over $136 million that retirees don't have to pay in premium in calendar year 2025 and stays kind of in their pockets. From their actual experience of what they were paying, that $533 to $420, it'll feel like $54 million. The other difference with to get up to $136 million, that difference is the cost avoidance of what they would have paid but for the board's action and the change in structure. And so those are some pretty profound numbers and significant impacts. That drop in premium was essentially kind of unwinding roughly 1 year, a little bit more than a year's worth of the premium increases that had been happening in the prior 2 years to the plan. But I think it's pretty important to highlight that the type of work that boards do can have that profound of an impact on members' lives. That's like I said, $136 million that stays in retirees' pockets this year because of the work that HCA did to bring to the board, and the board authorized a plan design change that didn't have any significant change in actual coverage, but just restructured to be able to leverage different types of federal subsidies in a way that could drive down that cost. So just wanted to highlight the profound impacts that can come from all of this work.
And getting over the hurdle of less money can mean the same product. Shockingly difficult to get over that hurdle. So a lot of great work done by the team to talk to retirees and to explain to them the benefit and where the additional funds came from, obviously through the subsidies through the federal government. But yeah, that was fantastic. Other questions or comments from the board? Dave, what is our board season looking like?
There's nothing going on, so it's going to be incredibly boring, nothing to talk about, no presentations. We'll be in and out before you know it.
Excellent. We'll see you later.
So, no, obviously, I'll talk more specifically about the March board meeting. So by then, we will have a better sense of where a lot of bills are in the legislative process. We'll be past the fiscal cutoff. We won't be past the first floor cutoff, but the number of bills Kate talks about, I can't say will be more or less because there's still a lot of bills to be introduced for the next couple of weeks. But we'll have more of a finite set of bills that are kind of in play for the legislative process. We probably won't have very much on the budget updates. The next board meeting is, I'm not sure exactly when the March revenue forecast is, but I'm pretty sure it's not before March 6th. It's usually closer to St. Patrick's Day. So we probably won't have too much to report on from a budgetary standpoint, unless Governor Ferguson presents additional context and details on his budget priorities. Then we'll obviously bring that to the board for your awareness. March is when we kick off usually our policy and rules development process, also known as resolution time, not for action, but the introduction. So if there are specific resolutions, we kind of expect that next month to begin that process. Remember to think about the board season as March and April-ish is policy rule time, and then May, June, July-ish is rate time. So, you know, we'll be talking more about the policy rules piece for the next couple of meetings. We're also anticipating bringing you more information about how benefits 24 stabilization is going, because if it's the number one priority, then we need to be talking about it everywhere all the time, all at once. And then, you know, appeals from the open enrollment process usually aren't flowing too fast by the time we're preparing for the retreat. We get a better sense throughout February as to kind of what the volume of appeals is related to open enrollment. So we anticipate we'll have a update on the open enrollment appeals process. And that's also another indicator of stabilization or lack thereof in the system. So those are a couple of key pieces. I do think those are some of the key things that are on board for March. More to come. I never give you a full cast of characters. No good teaser would do that because then you don't watch the movie. So those are a couple of things for March.
Excellent. I think we're open for public comment now. So I don't see much of the public in the room. So is there anybody in the room that would like to make a public comment? I did not think so. And out in Zoom land, is there individuals who'd like to make public comment? We're getting a list going and we're gonna call those folks up.
So for this process, Chair McDermott, I do want to highlight, given the Zoom security issues we had earlier today, we're going to be careful during this public comment as we get the understanding of this process down a little bit better. If for some reason we have to terminate public comment, we just want to reinforce that anyone who needs to provide public comment or wants to provide public comment can do so in writing. So you can submit that to the healthcare authority directly, and it would be sebboard@hca.wa.gov. That's SEBBOARD@hca.wa.gov. That's just as an extra precaution, and it's also on the agenda, that email, if you need to provide public comment that way. So we will do our best, but if for some reason we need to terminate public comment as we're understanding the security pieces, we apologize in advance.
And we'll get this figured out for subsequent meetings now that we're going to be utilizing the system differently.
So the important piece for a member of the public when speak is keep your virtual hand raised. People will be promoted individually into the presenter function so that they can turn on their audio and camera to be able to speak, and then you will be removed as a presenter and the next person will be brought in. So there will be a slight hiccup and scary circle that makes it seem like you're being kicked out of the entire meeting when you're really being promoted. Just hang in there and you should get into the presenter status as you're called on one by one.
What do we have?
Shirley.
All right. Shirley, you're up.
Yes. Well, hello. This is a lot. I've been listening in, and this is a lot. I had kind of a list of some things that I wanted to say. When SEB took over, I've been with the school district for like 30 years, and when when SEB took over, I was a big loser in benefits. I pay $1,200 easily more a year in medical. My dental has gone, we pay what, $1,104 for Delta. I have $1,500 worth of coverage. I used to have 19. I pay a $50 deductible. I pay 20% of fillings. I pay 30% of crowns. So I've gone from a very good dental plan to a plan that really I spend a lot of money on. Same with Vision service plan was phenomenal. I was able to afford glasses. Now I think last year there was $150 for frames. Now there's $200. Now it's every other year. And it's just, I just can't say enough about how our plans have gone downhill. And okay, I'll just go ahead and take it. Thank you. Okay, yeah, I'm at work. Yeah, so and one of the things I was gonna say was like, because we have to pay. Bye, thank you for coming in. All right, bye-bye. Sorry. One of the things I was gonna ask about was like, because we have to pay so much more, why our employers maybe aren't pitching in. And like now you're offering $200, which I think is phenomenal. But the income level, 40,000, a lot of our pairs are gonna be able to access that. But us people in the middle, like I'm an office manager, so teachers, like as our benefits decline and our costs go up, teachers have the ability to make additional money throughout the year. They get stipends, they get extra money for meetings, they can move up on salary schedules based on education and all this. So if their costs go up, and I'm not saying it's any easier for them, but they have the ability to create extra income. Classified staff do not. So what SEB has done for me is taken a lot of my income and given me less benefits. And I always say that, like, when the government steps in and starts doing things like this, I always say, like, I'm more than willing to take anything that you take, but I have a feeling, okay, I'll be done in a second. But I would like to see the plans that this board has, and some of the plans that, other people have, and yet our plans are declining and our costs are increasing. And there's nothing I can do about that. I have no control over it unless I want to take a high deductible plan, which financially could be devastating for me. So I'm no longer able to access AFLAC. So I just, sorry. Hi. Anyway, here, I'll go ahead and take that. Thanks for coming in. And yeah, just go ahead and sign out.
This is the first.
Yeah, I am so sorry. It's the ending of school because I thought public comment was about 3:30, which would have been a lot better for me. Bye.
I think it's helpful, Shirley, for us to see how school employees interact. I mean, that there's a value to the experience of your public comment.
Yes, well, here, I'll go ahead and take them. We'll see you tomorrow, okay? I'll go ahead and take them.
The only thing that would be better is if they were all enrollment forms coming in.
Yes, okay. No, I'll get you tomorrow, okay? All right, we'll see you tomorrow. Thank you. Thank you. All right, bye. And my door is closed. No, you're fine. And my door is closed. Anyway, I think the biggest thing for me, I mean, just hearing a lot of what's going on, the biggest thing for me when I was thinking about just popping into this meeting was just letting people know that when you raise our costs, when you take away our benefits, I need glasses. And right now I can't afford them because in my previous plan with the vision service plan, I had good coverage for my lenses. I had great coverage for scratch and all that stuff. It was all, I mean, I could get a great pair of glasses and now they go, okay, well, that'll be, $400. I'm like, I don't have $400 for a pair of glasses. And I would love to see that $200 extended up a little bit. Not many people make $40,000 a year. And even if you do make more than that, it's still not a sizable income. So that's kind of what I had to say. I wish I could have been a little more clear in my, hey, Joseph, how are you? So, hi there. Oh, thank you. All right. Yeah, of course. Okay, and so that's about it. I did have a little bit more, but like I said, we're dismissing school right now. So when I hope when you're thinking about benefits, I even had to, like, my benefit for my mastectomy bras has gone down. And I don't know if you've ever tried to buy one, but they're pretty expensive. And so they've gone from $58 down to 40. The insurance will cover 48. So, bye. Anyway, that's kind of what I had to say. I'm sorry if that was disjointed, but maybe I'll get in on the next one.
We appreciate your comments and fighting through work and providing the comments. We do appreciate it.
And surely usually with public comment, we hear and we don't engage on specific pieces. But one thing I did want to address for you and everyone else in the public is the benefits that any board member has because they happen to be an employee and meet eligibility is the same benefits as everyone else in the program. And so our board members who are here representing school employees who are eligible, they have the exact same benefits that every employee has. Whether our line is whether you're the superintendent or the bus driver, everyone has the same benefits. And that's true for board members who are serving that happen to also be school employees.
Yes,
yeah. So I just wanted you to be aware of that. And on the PEB side, like Lou and I, who are healthcare authority employees and employees of the state, we have very similar, and sometimes the benefit design is even less than what school employees have. And when it comes to dental, there are actually some improvements in the dental benefit that were made on the SEB side of the house that weren't made on the PEB side of the house. But in general, state employees and everyone who serves on this board who is eligible for either PEB or SEB benefits, it is all the same exact type of benefits.
And maybe unlike the federal government, where the legislators in the federal level might have different benefits, our legislators have PEB. So they all have the same as all the school employees, as the governor, as all the governor's staff. So it is.
There isn't a two-tiered benefit structure for somebody.
Yeah, and I guess
I just wanted to make sure you were aware of that.
No, I looked at what I was looking at was like I looked at like the city employees and I looked at their benefits and it's like under PEB, the city pays for the employee, all the employees, dependents and everything. And I think part of the problem is depending on what you make, like $100 a month, may not be as much for somebody who's making, you know, a teacher who's making $80 or $90 an hour as opposed to an office person who's making 35. So, I think that has to be considered that, some of us don't have access to making extra money. Some of us are making, and not saying that everybody is. I'm just telling you from my point of view and in working in the district, and I've always enjoyed, that's one of the things that even though I make a lot of money, I'm like, I've got great benefits, right? I've got all this stuff covered. And now I'm like, I'm paying, $1,200 more for my medical and my dental, unless I go with Willamette, and I switched to Willamette, and now I'm having to have that work redone. So, I guess it just, how much you make is relative as well as, benefits.
Thank you, Shirley. Very much appreciated.
All right. You guys have a great day. I learned a lot today.
Outstanding. Take care.
You too.
Others?
Bartolo?
And Bartolo.
Promoting you to speaker status. You have to accept.
Hello.
Thank you. Yeah, you have to accept our speaker status, but we can hear you. Go ahead.
Okay, perfect. Hi, my name is Melissa. I work as a BA at the Lake Washington School District. And I just wanted to go ahead and voice a few concerns about the benefits 24/7 and the ONT, I think ONT, where we send our tickets to over when we have concerns. We faced a number of issues during open enrollment, as we discussed earlier today. And unfortunately, we do have a high number of employees, and we faced more than normal on concerns, and the time it has taken for issues to be resolved has been longer, understandably due to how many representatives are available to assist all other districts through the state. And one of the frustrating things that we have been facing is when we send in a ticket, it will get marked as closed or resolved when it has not been resolved. So it now created an extra task for us where we keep track of all the tickets that we submit so we don't lose track of them. Once they're closed, they go into a different part where we have to go through the closed tickets and find that specific ticket to see what we missed. Sometimes we don't attend to the tickets as soon as they're responded by an HCA rep, which backlogs us a bit. We have to do our own research there, go back to a ticket. We can't reopen it, send in another ticket to follow up, and it's just a lot of running around. I've discussed it with other BAs, and that's just another issue where it's like, why are they being marked as resolved or closed when the issue is still pending? It's not fixed, or we have not been able to respond or don't have the opportunity to respond regarding that employee's account. And when it comes down to issues that we face, whether it's an employee and their dependents not showing active, their dependents being removed due to some sort of bug, I mean, I understand their frustration. We have employees who have gone months, a few days without coverage, but then what plays in hand with all of that is they start getting the medical bills and they're concerned about going to collections. When can they resubmit claims? And we're just like, the BAs are just the messengers between HCA and the employees. We've had issues that have been escalated to the unions, and we try our best to be sympathetic with the employees, try to explain, but we can only provide so much information. They feel frustrated that they don't have anywhere of who they can contact that's above us to voice their concerns. So I guess all in all, we were greatly appreciative of the email that we received stating that there will be more follow-up on the issues and the bugs that are coming through. But at the same time, we do also need to see a little bit more action in the sense where if we're sending in tickets, let's go ahead and follow the process and not just mark them as resolved or closed. And that continued to be an issue. I'm not sure if I explained myself well.
Yeah, you did. I think we understand what you're saying, and we're probably gonna look into it, because I'm looking at Dave, and he's probably not thinking, yeah, we close tickets before we finish the work. But there could be a file transfer, there could be a lag, could be something like that, but we'll take a look at that, because we can understand how that would look from your perspective.
And can we just capture your first name for the record? Melissa? And I want to say, part of this pivot to additional communications, or rather more targeted communications on a more consistent basis, is we're really recognizing the longstanding frustration that really has been exacerbated after open enrollment with the volume. And the other piece that I think is important is, as we're putting more on the benefits administrators' websites about the issues that are being triaged, there are pieces that everyone's aware of, but few people are aware of the extent of populations that we serve, and how, it might seem like this one seems like it impacts 1,500 people or 1,000 people. Where is that in the triage? Like, oh, we addressed the one that was 2,000 people, but it doesn't impact the population that an individual is necessarily serving. So I think just being able to, that's where some of this transparency and awareness as to the types of bugs and the extent of them and which populations they hit. If something hits retirees, benefits 24/7, that's not something that anyone in the SEB world would realize is also being triaged along with things that are happening on the school employee population, or with a file with the University of Washington, which is a quarter of the PEP population. There's a lot of different pieces of moving. I think just opening up the doors to what all is being worked on will at least give some of the context as to some of the delays or the anticipated timing of pieces. But we recognize the amount of work, and as you said, Melissa, you're in a middle position between, and really the front line of this kind of decentralized model, and we realize the challenges that faces and the amount of extra work that is being put on everyone, both in and out of the healthcare authority, but especially outside of the healthcare authority, whether it's another sister state agency or a school district or a higher education institution. And that's where we're much more on all hands on deck, as we're really dealing with the additional volume that has come up after open enrollment. So there's a lot of work to come. There's a lot of hard work being done everywhere. And we're going to keep digging our way out, but being transparent about where things are and how many things are being worked on and what are anticipated timelines for it, through our pivot on our communication efforts that started last Friday and will continue tomorrow.
Thank you for your comments, Melissa.
Yeah.
Do we have additional? Nope, seeing none. Our next meeting is going to be March 6th, starting at 9 a.m. We're going to use the same format of attendance, in person or via Zoom. The enhanced Zoom. We've sort of learned our lesson. Dave, any final comments before we adjourn?
Just thank you, everybody, for a long day, but shorter than we thought.
All right. And to staff, I really do appreciate you guys dealing with that on the fly, IT coming in and sort of making it happen. That was, yes, that was not good. So I hope everybody has a good day, and this meeting is adjourned. Take care.